Hello everyone, this week we're going to be looking over skull patterns as part of our clinical imaging course this week. With the skull, there's 11 different ways that the skull can show us that something is wrong. Again, this course is not for us to be able to diagnose, but it is for us to become familiar with looking at some of the patterns that we're seeing on our patients' images. All right, this slide just shows us the 11 possible patterns that we might see on a skull image. All right, and it's a lot of patterns there. So I know for me and probably for you, it can probably be a little overwhelming because our job is really just to take the picture, that diagnostic picture for the diagnosis. But these particular patterns can actually help us organize and identify what's actually going on in the patient's skull. So some of the patterns that you're seeing right here involve the shape and structure, all right, like basilar invagination and Wormian bones. Some of the patterns involve bone density. Is the skull losing mineral density or bone density and becoming more radiolucent, or is it actually becoming unusually dense and also white on the image? Others involve things like focal lesions where we see an actual hole or some sort of abnormal area in the skull, or it can also be in the mandible as well. And last but not least, some of these patterns involve some of the structures inside or around the skull, like the sella turcica, the paranasal sinuses, and also intracranial calcification. So when we see an abnormal skull image, we're not necessarily immediately asking ourselves what the disease is. We can start a little bit more simple if we know the patterns or are familiar with the patterns. So some of the things we might ask ourselves is, where are we seeing that abnormality? And what does that abnormality actually look like? Again, we're not making the diagnosis, but we should be interested in what we're seeing. Is the problem that we're seeing associated with the shape? Is it associated with the density? Is it associated with something inside of the skull, or is it associated with some sort of focal hole? So again, once you can put these findings into a category, it can narrow down what the possible diagnosis for that patient is again. So again, that is why we're using these 11 patterns to kind of approach this skull pattern chapter. So each week we've been starting out with some sort of analogy. So this is the analogy that we're going to use for looking at skull patterns. So it basically wants us, when we're looking at the skull film, it wants us to think of it as doing some sort of home inspection. So if you've ever purchased a house or you've ever rented an apartment or rented a place to stay, it usually begins with, hopefully, some sort of home inspection. So you're inspecting what is there. So when we're talking about home inspection, so that you can, if you're buying a new house, get it fixed without any cost to you. If we're talking about an apartment, you can identify what's going on within the house so that when you leave, you're not going to have to pay. But in terms of when we're looking at skull patterns, we're going to think about it as doing a home inspection. All right, and we're going to ask 4 questions, and we'll talk a little bit more about the 4 questions on the next slide. But those first thing we're going to do is we're going to check the foundation, and we're also going to check the frame. So with the skull, we're looking at, is that skull normally shaped? Is it shaped like it should be? We're looking at the base of the skull. Is it in the correct position? We're looking at the sutures and whether or not they developed or closed like they should have normally based on the patient's age. So we're basically asking, is the structure of the house normal? Is the structure or what we're seeing on the skull imaging normal? All right, the second thing we're looking at is the wall. So here we're going to be looking at the overall bone density. Does the skull look too dark because we're losing some of our bone density, or does the skull look unusually white because there is some sort of increased bone density? So again, we're asking whether or not the walls have the right amount of material in them per se. The third question here is we're looking for holes in the walls, and these are what we call osteolytic lesions if we're talking about skull lesion, bone lesions, or the skull itself. So these are the areas where bone has actually been destroyed. And when the bone destroyed, remember, one hole versus multiple holes. When bone has been destroyed, it's going to create or leave some sort of vacancy or a hole. All right, so if there's one hole or multiple holes, it will kind of point to, lead, direct, or guide, or give a clue as to what is causing that condition. So the patient's diagnosis is what we're looking for here. All right, the last question is what's going on inside of the rooms of the house. So now that we're looking beyond the skull bones themselves, now we're checking structures like the sella turcica, the sinuses. We're looking for intracranial calcifications. We're looking for, enlargement. We're looking for masses. So we want to know what's actually going on inside of the house itself, or the skull itself. So again, these are just some questions or some clues that we can ask. Again, when we're looking at the foundation and frame, it's primarily talking about the shape of the skull. If we're looking at the walls, we're talking about the density of the bone within the skull. If we're seeing holes, we're talking about some sort of destruction going on within the skull. And then last but not least, if we're looking at the individual rooms, we're talking about what is actually happening inside of the skull that's causing this appearance on our film imaging. So again, this is just a starting point for organizing some of the pathology that we might see on the image. Again, we're not making the diagnosis, but we do want to know what normal looks like and what abnormal looks like. Here's our 4 questions or 4 buckets that we're going to use to help organize some of the skull patterns that we're going to look at in this skull pattern chapter. So basically it's just, and we're not trying to memorize all of these patterns, all of these diseases, but we do want to look at basically what is abnormal in terms of what's going on in that patient's skull. So here's the 4 buckets. The first one is there a problem with the shape of or the structure of the skull? All right, so again, earlier we talked about a foundation or a frame of the house. So is that skull shaped normally? Is the skull base where it should be? These are when conditions like basilar invagination, also multiple Warmian bones can fit into this category. The second question or bucket that we can organize these things into, is there some sort of change in the bone density? So in other words, does most or all of the skull look too dark? Does it look normal, or does it look too white? Too dark means that we're seeing a decreased mineralization or some sort of loss in bone density. Too white means that we're seeing some sort of increased bone density. So this category also consists of what we call the density change category. The third question is there a focal hole or some sort of lucency or some sort of lucent area that we're seeing in the skull? Now, we're not talking about the entire skull. We're looking potentially at one or several specific areas of bone destruction that's happening in the skull. When we're seeing these focal osteolytic lesions, this can point us to things like button sequestration that we just talked about. The last category or question is there something abnormal inside of the skull? So here, the skull itself might not be the main problem. We might see changes or notice changes in the sella turcica area. We might notice changes in the paranasal sinuses. There might be some abnormal intracranial calcification. So again, we're not trying to complicate these skull patterns, because obviously you're not going to be able to memorize all of these in 10 weeks or ever, because your job is not to diagnose. But again, we do want to know what abnormal actually looks like. Is the shape abnormal from what it normally should appear? Is the density abnormal to what it actually should appear? Is there a hole, or is there something abnormal inside of the skull that is causing other issues within the patient? So these are just our 4 questions to organize the 11 patterns that we just talked about. All right, these are some of the key measurements and mnemonics that they use to look at some of the skull patterns. So think of it like a quick reference slide, so to speak. Just some measurements and memory tricks to help them remember some things. So the first thing is the McGregor line, which is basically we're talking about how they evaluate basilar invagination. So they basically draw a line and look to see how high the odontoid sits in relation to the base of the skull. The next one is the celaturcica. It's like us if you already did your skull and procedures and you went over anatomy. It's a small depression in the sphenoid bone area. That is the location where a pituitary gland sits. If we see, or the radiologist sees, what they consider a double floor appearance, meaning there's two separate cortical lines along the floor, they tend to think that there's something expanding, causing that celaturcica area to become uneven or become eroded. For our skull lesions, to remember the difference between a donut lesion and a button sequestrin, a donut lesion is basically a loosened area surrounded by a dense rim, just like a donut. Like a donut has a hole, and then surrounded by it is the, of course, the donut itself. That's kind of what it looks like. With your button sequestrian, it's a small calcified piece of bone in the center, so almost like a button sitting inside of it. There are also some mnemonics. The first one is COOP, and COOP helps us with the major causes of basilar invagination. So congenital abnormalities can cause it, osteogenesis imperfecta can cause it, Paget's disease, and also osteomalcia can cause it. With the Help Me mnemonic, it helps organize some of the causes, what we call solitary osteolytic skull defects. When we talk about solitary defects, we're talking about where there's one area of the skull where the bone has been destroyed or the bone has been lost, and it's causing it to look a lot darker on the x-ray than it should be. So solitary means one, osteo means bone, lytic, we're talking about a breakdown or destruction. When we're talking about a skull defect overall, when we're looking at these things, we're talking about something that is abnormal, an abnormal area or a hole in the skull, not a, a hole in the skull. Let's leave it at that. The last mnemonic there is pork chops. It's another mnemonic for some of the disorders that we see that can produce what we call multiple wormian bones, which are basically extra little bones that we see within the skull sutures. So again, these are just some key patterns and also mnemonics that can help narrow down what could be causing the skull patterns that the radiologist sees. Here is our first skull pattern. It's called basilar invagination. So basically it means that the base of that patient's skull has moved upward, and that upward move is causing the upper spine. Specifically, we're talking about C1 and C2. We're talking about the odontoid process area is sitting higher than it normally would be. All right, so one thing we don't want to confuse this with is platybasia. Platybasia means that the skull base is flatter than normal. Basilar invagination means that there's an actual upward displacement. So again, this is your basilar invagination. Now, when we see this on imaging, not us, but when the radiologist sees this on imaging, one of the ways that they evaluate it is they use the McGregor line. So they basically draw a line from the back of the head or back of the hard palate to the lower portion of the skull. Hard palate is basically the upper, I'll say the upper portion of if you put your hand, put your tongue up against the roof of your mouth, that's the palate area. So they're drawing a line from that to the base of the lower portion of the patient's skull. When they look at that, they look at basically how far the odontoid is extending above that line. So if it's abnormally high, then that usually is going to support whether or not that patient has basilar invagination. So what causes this? Some of the conditions that cause it is either there's a softened bone or softening of the bone or a change in the development of the skull, typically in that upper C-spine area, so the upper neck. Some of the conditions, as you can see here on the right, that cause this are OI, osteogenesis imperfecta. Rickets can cause it, Paget's disease can cause it, osteomalcia can cause it. So again, if that bone becomes too soft, the weight of that patient's skull can actually gradually cause that skull base to deform, and we see that upward move. It can also happen with some of the congenital conditions, and those conditions include Klippel-Feil syndrome and achondroplasia, and it can also happen following some sort of trauma. Now, the reason why this space actually matters is because as the skull base starts to move upward, it can I'll say, close down or narrow that area around the brain stem or the upper spinal cord. And if that happens, the patient can potentially start having some sort of neurologic syndrome. So again, with basilar invagination, that skull base and the upper cervical structures are pushed upward. It usually is happening because there's some sort of softening, bone softening disorder. And the way that they evaluate it is they look at that McGregor line. This is another skull pattern, and it's called button sequestration. So when we're looking at it on an image, it actually appears like a small, I'll say, round area of bone loss with a tiny piece of, I'll say, denture bone or calcification in the center. Because of that appearance, we usually describe it as a donut, like the donut that you eat with the round circle with the hole in the middle. This particular finding, if they're seeing it, it's kind of important to know that this particular appearance can sometimes be normal, and it can also be harmless to the patient, especially when that area is smooth. It can appear well defined and have those sclerotic borders, and the patient can also have no symptoms. Now, we can't automatically assume that every lesion that looks like it's benign is benign, because there are some skull lesions that that can actually metastasize. So again, we're not assuming, we're not making the diagnosis, but this is what that appearance looks like. So we're not going to assume that it's benign. Some similar skull lesions can also occur with eosinophilic granuloma. They can occur also with infection, and they can also occur with metastatic disease as well. Previous surgeries can also leave this type of defect or this type of lesion. So one of the clues when we're looking at this type of presentation, they're going to be looking at the patient's history, their clinical history. Is this finding incidental? Is it painless? Also, are the borders that we're seeing or that the doctor is seeing well defined? So again, that's some of the things they're going to be looking at. If the patient has pain, if there are symptoms, or if the lesion looks very aggressive and we see areas of bone destruction, they start to become a lot more concerned about what type of pathologic process is happening behind the scenes. So again, with our button sequestration, it's a small round skull defect. Usually it has a dent center like a button or a donut. Again, we will not assume, if we're looking at this, that it is benign or not. We're not going to assume anyway, because we're not making the diagnosis, but there has to be some sort of clinical history also that comes with this presentation. The next finding is related to cystic mandible lesions, and it can be split into two groups. And when we're looking at the pathology of it, it can be seen anywhere in the skeleton, but the causes of it is usually tied to the patient's teeth. So with these cyst-like lesions, they can happen or occur in the jaw, and again, they're going to be related to the patient's teeth. So the main thing to pay attention to is, or the main thing that the radiologist or doctor pays attention to, is where that lesion is actually located. With our follicular cysts, They typically form around the crown of the patient's tooth, and that tooth, it's a tooth that hasn't erupted yet, with the periodontal cyst and also the periapial granulomas. They are usually associated with some sort of infection that the patient is having, and is typically near the root of their tooth. So some of the less common lesions are going to be the ameloblastomas, which typically can grow very large. And then we also have giant cell granulomas, which can actually expand and thin out the patient's jawbone. With the solitary bone cysts, they're typically going to be found in our younger patients, and they can typically occur after trauma. So again, when we're looking at cysts, we're typically going to see somewhat of a dark area surrounding the crown of the patient's tooth. When we're talking about specifically the crown of an uninterrupted tooth, we're talking about the follicular cyst though. This is our second category of cystic lesions of the mandible. The first category, we said that the cyst was being caused by something going on with the patient's teeth. With these, it has nothing to do with the patient's teeth. So it's jaw lesions, but again, not caused by the patient's teeth. Instead, they're coming from other diseases that are affecting the bones of the body. So when these are seen on x-rays, we might see areas where the bone has actually been destroyed or where the jaw is actually enlarged. A sign that they look for here is floating teeth. And floating teeth, basically, it looks or appears like the tooth is floating, but what actually happened is the bone around the tooth is lost, and it makes it look like the tooth is actually floating. And this is typically associated with histiocytosis X, but there are some other conditions like multiple myeloma, Paget's disease, infection, and also metastatic cancer that can show this floating tooth. Here's our next category of skull patterns. With this one, we're talking about diffuse demineralization. So it basically means that the bones of the skull are starting to become less dense due to a loss in some of the minerals. On an x-ray, they appear more radiolucent or darker. The most common cause of this diffuse demineralization is osteoporosis. Usually osteoporosis is associated with aging, but there are some other diseases that can cause similar changes such as these. Some conditions can give us additional clues for the skull finding. Certain types of anemias can produce what we call a hair-on-end appearance. We talked about this a little bit earlier in the term, that hyperparathyroidism can also make a salt and pepper appearance. And then if we're talking about multiple myeloma, it can cause a punch out appearance or area in the skull. All right, now we're moving on to Selloturcica signs or changes, Selloturcica patterns. Again, the Selloturcica is the area of the spine that holds our pituitary gland. Normally, the Selloturcica is typically smooth and it's a very well-defined area or appearance on our X-ray images. If it becomes enlarged or starts to look damaged, what they'll start looking for is what we call a double floor sign. With that double floor sign, we'll start to see two lines instead of one line along the bottom of the Selloturcica. What that indicates to the radiologist or whomever is reading the film is that there might be some sort of mass, such as a pituitary tumor, and that mass is usually causing some sort of uneven erosion in that area. Now, there's some other conditions that can cause the Selloturcica that to enlarge. One being maybe the patient has increased pressure on their skull, but again, the main thing here with the Selloturcica is there will be some sort of change in the size, some sort of change in the shape, and then also they're looking at the floor of the Selloturcica. The next skull pattern we're looking at is increased radial density of the calvarium. So basically, if we're looking at an X-ray, it means that those skull bones are appearing wider, brighter, or thicker than they normally would appear. And this happens when the patient has extra bone developing, or even the normal layers of the skull can become thicker or thicken. There are several conditions that can cause this, some that you have seen over the last few weeks are dysplasia, Paget's disease, and also acromegaly, but there's a few others. One pattern that they look at for this condition is a cotton wool appearance, and that one is typically seen when that patient might have advanced Paget's disease, where the skull has these irregular patches or increased density. So again, we're looking for unusually thick or white densities in the patient's X-ray image. The next skull pattern is intracranial calcifications. This is when we see small areas of calcium that show up on the inside of the patient's skull on their X-ray image or even on their CT. An important thing to know about calcifications is they are somewhat normal, especially as the patients are getting older. The radiologist or the doctor will become probably a lot more concerned when those calcifications show up in locations that they consider unusual. Also, when the calcifications start to appear on very young patients, and then also if that calcification has some sort of abnormal pattern. When we have these abnormal calcifications, they can be sometimes associated with a patient having blood vessel problems. There can be some underlying disease. There can be infection. Also, there can be tumors associated with these calcifications. So again, when they're seeing calcium inside of the skull, it doesn't automatically mean that something's wrong, but they do pair it with things such as the patient's age, the pattern, and also the location. The next skull pattern is related to the paranasal sinuses. Typically on an X-ray, because our sinuses are air-filled spaces around the nose and face, they're going to appear really dark, the darkest shade of black that we can see on the X-ray. Now, if the sinuses start filling up with something, and that something could be a mass, it could be blood, mucus, or fluid, on an X-ray, it will start to look cloudy or it can start to look white. So that means that there's something there in the space besides air. Now, sometimes the most common cause of this filling effect or this white cloudy appearance is the patient might have something called sinusitis. And with that, we're looking for, on the X-ray, we're looking for an air fluid level where we can actually see a line between the air and the fluid. That is a classic sign for the radiologist or doctor to say that the patient might have acute sinusitis. Now, trauma can also cause blood to collect in the sinus, and also things such as cysts and tumors, which are less common, they can cause the sinuses to look opaque on the radiographic image. So the main thing to remember when we're looking at the sinuses, a normal sinus looks very dark, and again, that's because it's filled with air. So if we start seeing the sinus looking white, bright, or cloudy, the doctor has to determine what is actually filling the space. The next skull pattern involves wormian bones, and wormian bones, as you're learning your skull imaging or as you learn with skull imaging, are basically small extra pieces of bone that form in the sutures or also in the joints of the patient's skull. Now, wormian bones are normal when we're talking about very young infants. So it doesn't necessarily mean there's something wrong if we're seeing it in a young infant. However, when we're seeing wormian bones in older children and also adults, it can be associated with different conditions that can affect normal bone development. Some of those conditions you learned about earlier, that's the osteogenesis imperfecta, also rickets and cleidocranial dysplasia, all of those can affect the wormian bones. So again, they're not necessarily alarming when we see it on younger infants, but when we see it later in life, we might, or the radiologist might want to take a second look or get, additional imaging to see if there's something underlying in terms of a bone disorder. The next skull pattern is solitary osteolytic defect. So when we're looking at these on an X-ray, we're basically seeing one area of the skull where there's some sort of bone loss that's been lost or destroyed. On the X-ray, it's going to look like a dark spot or a hole in the skull. And some of these findings can be harmless. So things like that donut lesion where we see the dark center surrounded by a white rim. While some of them can be harmless, there's some that can be of interest to the doctor to do some further testing. So some of these can be caused by things like surgery or trauma. Some can be caused by a cyst. Some can be caused by infection. The person might have a tumor, or there might be some sort of metastatic cancer going on. So when we talk about solitary, we're talking about there's only one area. And when we're talking about osteolytic, that means there's some sort of destruction of that bone happening in that area. So we looked at solitary osteolytic defects, so now we're looking at multiple osteolytic defects. So instead of just seeing one area of bone where it's lost, we're now seeing multiple dark areas or multiple holes throughout the patient's skull. So when they're looking at this imaging, the patient's age and the appearance of those areas is going to help the doctor or radiologist determine what the cause is. So one of the most important patterns to recognize is for this particular condition is multiple myeloma. When we see multiple myeloma on imaging, typically it's going to produce punched out lesions that look like someone just punched a lot of holes throughout the patient's skull. Metastatic cancer can also produce multiple areas of bone destruction, but they're often different sizes and less uniform. Another condition is hyperparathyroidism. It can produce some of these same widespread salt and pepper appearances. So again, the main thing with this one is we're seeing multiple lesions versus on the last defect, osteolytic defect, we were talking about a single or solitary one. All right, so again with this, these lesions, we're typically going to be looking at age. This typically is going to be seen in our older patients. And with this also, the doctor might start to lean toward multiple myeloma. The last skull pattern is related to radiodense lesions of the mandible. So we're basically, when we're looking at it on an X-ray, the area appears wider and more dense than the surrounding bone on the X-ray. So again, with this lesion, it is typical that they may change in appearance over time. They may start out looking dark. That just tells us that the bone is being lost. And then later on, as we continue with imaging, they might become white as new bone is actually starting to develop or calcify. A good example of these are cementoma, where we can start as a dark area and gradually become a dense mass, a white mass, and then odontoma can also appear very dense, and it also can contain some tooth-like structures as well. Infection and also other bone diseases can cause some of these changes as well. So again, with these types of lesions, we might see a white or dense area in the mandible. So again, with this, we're going to also be looking at the location. We're going to be looking at the appearance and also how the appearance changes over time. And that'll typically help the radiologist or the doctor determine what the overall cause is. All right, now we're wrapping up the skull patterns, and this is just our summary of what we discussed. So again, with those skull findings, typically the radiologist or the doctor is not going to base it on the skull appearance alone. Some of the things that they need to take into account when they're looking at a pattern is sometimes they may need to do measurements. They're also looking the location of the appearance, and then also the patient's age as well can be telling on what it is. Something that's normal in a baby, such as those wormian bones that we talked about earlier, can be very abnormal when we're talking about an older child or an adult. In the jaw, when they're looking at these, or when you're even looking at these, even though you're not making the diagnosis, we're looking at where that lesion is. Is it connected to a tooth? Because that typically is going to point more toward it being a dental cause. If it's not related to the tooth, we're typically going to consider some type of underlying disease that's affecting the rest of the patient's body. So another thing to remember is that, the x-rays may identify that something looks abnormal, but that patient may need advanced imaging modalities like CT or MRI to actually help assist in diagnosing what the underlying disease or cause or pattern is. So again, even though we're trying to learn how to recognize a pattern, we have to take into account the patient's age, the location of the pattern, and also measurements to kind of narrow down what possible diagnosis the patient will receive. Here's our quick review of some of the patterns that we talked about with regards to the skull. So again, we're not trying to memorize any of these diseases, and we're not even trying to diagnose any of the diseases. We're just trying to focus on trying to match what we might see in an x-ray with the pattern in terms of what we learn. So in terms of if we see that the odontoid is sitting too high above what we call that McGregor line, some of the things that we're going to think about is that basilar invagination. If we're seeing a dark area in the jaw surrounding the crown of a tooth that hasn't erupted yet, it might suggest that there is some type of cyst there. If the entire skull looks less dense or somewhat washed out on our imaging, we might think of demineralization. If we're seeing an enlarged sella turcica and we have that double floor sign appearance, it could tell us that there might be some type of pituitary mass or some sort of erosion going on. And if the skull looks unusually thick or white on imaging, that might point us to increased calvario radiodensity. So again, these are just some signs or some clues. We're not trying to diagnose, but of course, in our job, we're going to see some of these things. Now, even though skull imaging might be far and few in between, just because a lot of these patients go to CT now, there may be opportunities or chances that we see these things, and this just gives us an idea or a clue on what normal looks like versus abnormal looks like. Here's our final look at some of the patterns that we talked about with the skull imaging. The first one is calcifications inside of the skull. So remember, calcifications can be normal, especially when we expect them based on the patient's age, and also when they appear in a location that we typically expect them to be in. But when they're unusual in terms of the patient's age, unusual in terms of the location, or even the appearance, that can be a warning sign for us or for the radiologist and the doctor as well. If we're seeing an air fluid level inside of the sinuses, again, remember the sinuses are typically supposed to be filled with air. And if we're seeing that cloudy white appearance versus a dark appearance, because air appears dark, like you see the air in your lungs, that usually points to the fact that that patient might have some sort of sinusitis going on, some sort of sinus infection. If we're seeing multiple wormian bones, again, based on the patient's age, because in an infant, it might be completely normal, but in an older patient, that might suggest that they might have some sort of bone disorder. If we're seeing multiple punched out areas in the skull, especially if we're talking about an older adult, we might look at multiple myeloma as the cause. Also, if we see a dense or white lesion in the mandible, that might also point to a condition called cementoma. So Again, these are just patterns that we just learned about. We're not diagnosing the patient, but if we can identify that something looks abnormal, it might get the patient to their follow-on treatment faster, especially if we can bring it to the radiologist's attention prior to allowing the patient to leave. So again, looking at the patterns, not necessarily trying to memorize or recognize the patterns, but just have an idea of what these patterns look like, coupled with the clinical history and also the patient's age and some of the locations of these things can help us just be better at our job. Here's our final takeaway from our skull chapter, our skull patterns chapter. So again, our goal is not to memorize all of these diseases, and our goal is definitely not to diagnose as a technologist, but we do want to have an idea of what normal looks like and also what abnormal can look like. So instead, when we're looking at some of our images, especially with the skull, since we're focused on that, and we're looking for things such as, is the bone darker or wider than it normally would be? Is there one lesion or are there multiple lesions? Is the pattern involving the jaw? Does it involve the sella turcica? Does it involve the sinuses, or does it involve sutures? In terms of measurements, although we're not doing any of these measurements, those measurements can help us decide whether something is normal or abnormal. And last but not least, although we're not making the diagnosis, some of the things that are considered are the patient's age. They consider the symptoms, and again, they consider these as well as the locations. They consider these because some of the findings, like wormian bones and also some of the calcifications that we might see, they might be completely normal for one patient, but abnormal for another patient based on their age and also based on the symptoms. So again, somewhat trying to identify the pattern first, although we're not memorizing any of these things, looking at where the location is of the pattern. Typically, we're not making measurements, but the doctor or radiologist will make measurements, thinking about or looking at their age and also some of the symptoms or their clinical history to kind of narrow down what the cause is. Our next topic is spine patterns, and as you can see right here, there are a lot of diseases that fall into this category, and there's also 13 patterns. So 30 plus diseases and 13 patterns. That's a lot of things for us to try and memorize. So again, we're not trying to memorize them. We're just trying to see what normal is versus what abnormal is. So in the same fashion as we've approached this book already, the author wants us to look at the spine itself as building blocks. So we're looking at the vertebrae that stack on top of themselves from C-spine all the way to the L-spine as building blocks. So when we're looking at the image, we are kind of asking the question, do those blocks or do those vertebrae look normal? Are they too dense? Are they too thin? Are they enlarged? Are they squared? Are they flattened? Are they damaged? Is one vertebrae affected, or are there several vertebrae that are affected? If we can identify these, or if the radiologist can identify this, that gives him or her a better choice or start at narrowing down what the actual disease is that might be responsible for what we're seeing on the image. So again, our focus is more so on recognizing some of the patterns versus trying to memorize all of these diseases. Here are the 13 patterns that are used to evaluate spine images. So again, this is pretty overwhelming if we're just looking at it and thinking that we have to figure all of this out. But again, we're just kind of trying to find a pattern, looking for what's normal versus what's abnormal. So we're going to usually start by asking ourselves, does the image look abnormal? Has the shape of that vertebrae changed? Is the disc space potentially narrowed? Is there any additional bone growth that we might see? Is there any destruction of the bone? Has the vertebrae collapsed? Is there a change in alignment? In addition to that, we might start looking at the structures around the spine. Some of those structures are going to be the SI joints, I'm sorry, the SI joints, sacroiliac joints, and also some of the soft tissue next to the vertebrae. As we look at these patterns, we're going to focus on what it looks like on the image and what part of the spine is actually affected as well. And if we can identify this, it's going to be easier to help narrow down some of those possible diseases. So the 13 patterns deal with altered vertebral shape, narrow disc height, radiodense vertebral stripes, end plate alterations, atlantoaxial subluxation, bone outgrowth, scoliosis, osteolytic spine lesions, sacroiliac joint disease, paraspinal mass, disc calcification, ivory vertebrae, and collapsed vertebrae. And if I didn't say the last one is scoliosis. All right, here we're looking at our analogy, and we're also looking at the questions that we're going to ask ourselves, or that the radiologist is going to ask themselves. So we're thinking of the spine again as a stack of blocks with cushion in between them. So the blocks themselves are the vertebral bodies, or the vertebrae, and the cushions in between them are intervertebral disc. All right, the job of the intervertebral disc, they act kind of like shock absorbers in between those vertebral bodies, and they help the spine bend, they help us move, and they also help somewhat absorb pressure instead of having the bones rub against each other. All right, when we're looking at a spine X-ray, we can ask ourselves these questions that you see right here. The first thing we're going to ask is, what do the vertebrae themselves look like? All right, are they what we know to be normal in shape? Are they abnormal in shape? Meaning, are they wedged? Are they enlarged? Are they squared, or are they flattened? The second question is the spine lined up correctly? If it curves to one side, we might be looking at something called scoliosis. There's other curvatures that can occur as well with lordosis and kyphosis, but scoliosis is the one presented here. Another thing is if the vertebrae are slipping out of alignment, we might need to look at some alignment problems. The third question is, we're going to look at the spaces around and between the vertebrae, especially those disc spaces in the joints. We're looking to see if they're narrowed, or are they abnormal in some way, or are they calcified? And then the last question that we're going to ask ourselves is, we're going to look at the bone itself, and we're going to look to see if the bone is normal, or if it looks like there's some sort of bone destruction going on. Is it, or does it appear dense? Is it collapsing? And again, all of these questions, these 4 questions, will help us with recognizing some of the spine patterns that we'll see in this chapter. All right, so we have our 4 questions that we're going to answer, and we have those 13 patterns. So now what we're going to do is put all of that into 4 groups per se. So when you look at the X-ray, the spine X-ray, again, we're going to start by asking some questions. The first question is, what actually changed? Did the shape of the vertebrae change? Such as, did it become wedged? Is it enlarged? Is it squared? The second question is the spine out of alignment? Or not question, second group, is the spine out of alignment, like we see with things like scoliosis? Or is there a vertebrae that has shifted out of position in some way? The third group is we're going to look at the spaces and also the structures around the vertebrae, and that includes the joints, and that also includes the intervertebral discs, those cushions that sit in between. Are they narrowed? Are they calcified? Or are they abnormal in some other way? And then the last thing we're going to do again is we're going to look at the bone itself. Is that bone normal, or does it appear normal, or is it destroyed or being destroyed in some kind of way? Is it dense, or is it white, or has the vertebrae collapsed? So again, the 13 patterns, we're starting with 4 questions, and with the 13 patterns, we're looking at shape, We're looking at the spaces, we're looking at the bone density, and we're also looking at the alignment. There's a few important measurements and clues or mnemonics that we can use or that the doctor uses to help narrow down what we see on a spine image. The first one is ADI, or atlantodental interval. That actually measures the space between the first cervical vertebrae and the dens. Normally that space should be approximately 3 millimeters or less in an adult and 5 millimeters or less in a child. So if we see an increased space, that can indicate that there's some sort of instability in the spine. The next thing that you see there is the Cobb method, and that's used to measure the degree of that spine curvature when we're evaluating things like scoliosis. So on this slide, it gives us two memory call to tools or two mnemonics, and those mnemonics are call home and also go ape. So call home basically helps us remember some of the causes of destructive lesions that involve the vertebrae, and go ape helps with the lesions that involve the back portions of the vertebrae. Another helpful tool, I'll say, is, or clue, is a vacuum phenomenon. So when we're seeing this, or when we hear about this, it basically means that we see some sort of gas within the disc space, and that usually tells us or points to some sort of degeneration rather than an infection. The last thing is when we're looking at the SI joints or the sacroiliac joints, one of the things that we're going to be paying attention to is whether or not the changes that we're seeing there affect both sides equally, or both sides differently, or is just one side involved, because that pattern again can help narrow down some of the causes of what's going on with our patient. Here is our first case file involving spine patterns. And this one we're looking at an altered shape. So the change in the shape here, we're looking at a change in the shape of the vertebral body. It's called a beaked or hooked vertebrae. So basically part of the front of that vertebrae is sticking out, and it looks almost like a small beak, like a bird beak. Now, the location of the beak can actually give us somewhat of a clue about what the cause is. In achondroplasia, that beak is usually lower and on the front of the vertebrae. With Morquio syndrome, it tends to be more toward the center. In children, we also have to be careful because some of the normal bone development that they're having can sometimes create a similar appearance that will eventually disappear as that vertebrae matures. So the main thing to remember is when you hear the beaked vertebrae terminology, think about it's being an abnormal projection or a point along the front of the vertebral body, and then look at where the beak is actually located. All right, but age also matters as well, because it could be a normal development process in children. This is our second case file, biconcave vertebrae. We're still talking about abnormal shape. And this basically means that the top and the bottom of that vertebral body, they curve inward instead of staying relatively flat. So one thing you can think about is if you have a marshmallow and you pinch in the middle of the marshmallow, it kind of gives us somewhat of an hourglass shape. That's what we're talking about. Now, this can happen when the bone becomes weak, such as when a patient might have osteoporosis or some other metabolic bone disease, or it can also happen when part of that disc starts pushing into the vertebral body, something that we can see with Smurl node. One of the things that or patterns that you should recognize is sickle cell disease. So this actually causes the vertebrae to develop I'll say a more distinct shape. It's an H-shaped appearance. So again, the main thing to remember when we're talking about biconcave, that means that the end plates curve inward. And when I say end plates, I'm talking about either the top or the bottom of that surface. And when it's curving inward, it makes the shape more like an indentation. So that can give us somewhat of a clue of what the cause is for that spinal shape abnormality. All right, now we're moving on to block vertebrae. We're still in the abnormal spine shape or vertebral shape. So when we're talking about block vertebrae, we're basically saying that two or more of those vertebrae have fused together or they've stuck together instead of being separated normally by that intervertebral disc and that disc space. This particular shape can be something that's congenital, meaning that the person was born with the fusion, or it can be acquired, meaning that the vertebrae fused together because of some sort of disease or surgery, trauma, and it can also be an infection. A condition that's associated with a congenital fusion is Klippel-Feil syndrome. So basically, with this syndrome, it usually involves a fusion of the vertebrae in the person's C-spine or their neck area. When we're looking at the person's X-ray, one of the biggest clues when we're talking about block vertebrae is we're looking at the disc space. If the vertebrae never separated normally during development, then the disc might be small or it also might be absent. If the fusion happened later on in life, meaning they originally had a normal disc space and it was eventually lost, then that would point to some other type of condition that's acquired later in life. So again, the main thing to remember when we're talking about block vertebrae, it basically just means that that neighboring vertebrae, the one on the top or the one on the bottom, has fused, like we've glued it. It's fused together, and we have to be able to determine whether that fusion was present at birth, meaning it's a congenital defect, or whether they developed it later on in life. All right, next we're moving on to wide or enlarged vertebrae. So we're still talking about the shape of the vertebrae. So compared to, if we're looking at an X-ray, compared to the vertebrae that is above or below the affected vertebrae, that vertebrae or vertebral body is going to look like it's grown wider than it should be, or it's expanded more than it should be. There's two big ways to think about this particular shape pattern, and the first thing is it a systematic condition? Systematic conditions can cause bones to enlarge. So an example would be something like acromegaly, where there's too much growth hormone, and that growth hormone is going to cause enlargement of the bones throughout the body. The second possibility for this type of shape pattern is if there's something else that's growing or expanding within that vertebrae, and that something else could be a bone lesion. That bone lesion could be malignant, or it also can be benign. So as that bone lesion starts to grow, it starts to push that bone outward, and it makes it actually look like that vertebrae got wider. So one disease that we've gone over so far that we associate with some of these appearances when we're talking about wide and large vertebrae is Paget's disease. With that disease, the vertebrae can become enlarged. It usually has what we call a thick outer cortex. If we're looking at it on an X-ray, we're looking at, it can create what we call a picture frame vertebrae. So basically the outside edges of the vertebrae body look pretty thick and dense, almost like the frame around a picture. So again, there's so many shape categories that we've talked about so far, and there's a few more that we have to talk about. But again, the vertebral body for this one is too wide. So we're going to ask ourselves, is it the bone overgrowing itself, or is there something inside of the bone that is actually expanding it from within? All right, we're still talking about abnormal shape patterns of the spine, and this particular pattern we're talking about is a tall, enlarged vertebrae. So it basically means that that vertebral body is taller than we normally would expect for it to be on an image. This particular pattern is actually much less common than seeing a vertebrae that has lost height, meaning it's shorter than it should be. One of the first things that we should consider or want to consider is what we call a block vertebrae. So if you remember the block vertebrae, it happens when we have two vertebrae that are fused together. So on an image, those two fused vertebrae can sometimes look like one unusually tall vertebrae. So we want to make sure that we're not being fooled by what is considered fusion versus a tall or enlarged vertebrae. Another possible cause is what we call gibbous deformity, and this is basically it's a sharp angular curvature on the spine that can happen after some sort of destruction or collapse of a vertebrae, such as from TB involving the spine, what we learned as POTS earlier in the term. Over time, these abnormal forces on the spine can somewhat change the height and also the shape of other vertebrae as well. We can also see tall vertebrae with Marfan syndrome. These patients tend to have very long, very slender bones, and the vertebrae also might appear taller. They can also have scoliosis and also widening of their spinal canal as well. So for this pattern, just to keep it simple, the vertebrae look tall. Before we assume that the vertebrae itself grew too much, the first thing we might want to find out, or the radiologist might want to find out, is are two vertebrae fused together, or is it actually a tall vertebrae? All right, now we're going to look at anterior scalping of the vertebrae. All right, going back to medical terminology, anterior basically just means the front. And when we talk about scalloping, we're basically talking about, instead of the front of that vertebral body being fairly straight, it has an appearance that there's something scooped out of it, or something, there's like some sort of indentation there. An easy way to, I'll say, picture this is, let's say you have, again, a marshmallow, or you can have a piece of clay. If you press your thumb and your finger together on that clay, that is what we have happening in that, some sort of indentation. So something sitting in front of the patient's spine can put pressure on that vertebral body over time. And if that pressure stays, then there will eventually, it'll cause some sort of indentation. One cause that we see in this type shape abnormality of the spine is the patient might have an aortic aneurysm. With that, the aorta sits directly in front of our spine, and if it becomes enlarged, due to the fact it's constantly pulsating all the time, it can slowly cause erosion to the front part of that vertebrae. So when an aortic aneurysm causes this type of appearance, we call it Oppenheimer erosion, is what they call it. Enlarged lymph nodes or other masses can also press against the vertebrae, and it can also produce this scalloped appearance as well. One of the clues that also help us when they're looking at this, when they're looking at that indentation, they're also going to be looking at the patient's disc space. So with pressure from something on the outside of the spine, like an aneurysm, that disc space will generally be preserved, meaning it won't be affected. But if there's some sort of infection like POTS or spinal TB, we might see that scalloping appearance, and we might also see that there's some type of disc space involvement. There's also a chance that we might see mass, a paraspinal mass as well. So again, when we're talking about anterior scalping, we're talking about something that might be pressing against the front of the vertebral body. In addition to looking at whether or not it's eroded or not, another thing that they're going to pay attention to is the patient's disc space to help determine what might be causing it, causing that shape, that scallop shape. So we just talked about anterior scapholing. Now we're going to talk about posterior scapholing. So just the opposite, instead of the front of the vertebral body being affected, now we're talking about the back of that vertebral body being affected. So again, where we see the indentation, it's now no longer in the front, it appears in the back of the vertebrae. So the back looks scooped out. So think about what sits directly behind the vertebral body. So what sits behind the vertebral body is our spinal canal. If there's something inside that canal that basically is causing it to enlarge, or it's creating some sort of increased pressure over time or over a period of time, it can gradually push against that vertebral body, and that pressure can create that scalloping appearance or that indentation. All right, an example of a condition that can cause that is dural ectasia. That's basically when the sac that surrounds the spinal cord, it becomes widened, and this can happen with conditions like Marfan syndrome and also neurofibromatosis. Tumors within the spinal canal can also create this pressure and cause this posterior scallop appearance. The findings, again, whether it's in the front or whether it's in the back, can help us narrow down the cause. Posterior scapholing, when we have with also a widened spinal canal, and a tall patient can point towards maybe a condition like Marfan syndrome. In a condition like achondroplasia, we can also see this posterior scapholing, but the spinal canal itself tends to be narrow instead of wide. So again, with interior scapholing, we want to think about something pressing on the front of the vertebrae. With posterior scapholing, we want to think about that pressure coming from within that spinal canal, which sits behind the vertebrae. Now we're moving on to the square vertebrae. So when we look at a normal vertebral body, they typically have a slight inward curve. There's some concavity there. With squaring, that little curve actually disappears. So the front becomes a lot straighter, and that vertebral body actually starts looking like a square or a box. A big condition or big disease that is associated with this squaring appearance is ankylosing spondylitis. So with ankylosing spondylitis, that vertebral squaring is actually one of the earlier x-ray findings or earlier things that we can connect that to when we see it on an x-ray. This is before we even get to what we call a bamboo spine appearance. Ankylosing spondylitis itself is considered to be an inflammatory disease. It commonly starts or begins somewhere around the SI joint, sacroiliac joint. So if we see a squared vertebrae along with bilateral symmetry changes in that SI joint area, we probably want to think about, or the radiologist or doctor probably starts to put ankylosing spondylitis really high on the list for the cause. There are some other inflammatory arthritic conditions, and those include psoriatic arthritis, and there's also reactive arthritis. They can also cause this vertebral squaring, and we can also see this squared appearance in patients that have Paget's disease. But with Paget's disease, the vertebrae is also usually enlarged and thickened, having those dense picture frame type borders that we talked about earlier. So the takeaway here is when we're looking at a normal vertebrae, there is a slight curve in the front of it. When we're looking at a square vertebrae, that curve actually disappears. When we see a square vertebrae plus some sort of symmetry change in the SI joint area or SI joint disease, we're looking at or should think about the condition ankylosing spondylitis. This is our last case file for shape changes. In this particular file, we're looking at a wedge vertebrae. So normally the front and the back of that vertebrae is typically similar in height, meaning it's the same height from front to back. and top to bottom. When we have wedging, usually the front of the vertebrae loses some of its height and the back of the vertebrae stays a lot taller, or its proper height. So instead of it appearing normal, it gives it kind of a wedge appearance. So if you think about, if you've ever used a doorstop or seen a doorstop that looks kind of like um, somewhat like a triangle, that's what we're talking about with the wedged appearance. One of the common reasons for a wedged appearance is the patient might have a compression fracture. So with a compression fracture, think about pushing down on the front side of a block or a front side of a marshmallow, not the center of the marshmallow, but the front side. If we're pushing down on the front side gets crushed or smaller or thinner, while the back side of it is going to remain relatively the normal height. So again, that is what a wedged appearance looks like. Now, if there's some sort of injury or recent injury, we also might see a small break, or maybe what we call a step in the cortex. So along with an area of increased density from that compressed bone, we will see, that step in the cortex and also a small break. Now, not every wedge vertebrae is considered to be a fracture. There are some wedge vertebrae that we see around the thoracolumbar region, and those can sometimes be what we consider to be normal. Another cause of a wedge vertebrae is Sherman's disease. So instead of one vertebrae being wedged from an injury, we typically see that 3 or more vertebrae are wedged together. So we also can see narrow disc spaces and also multiple Schmerl nodes, with which we talked about earlier. This also can produce a more exaggerated, what we call rounded upper back appearance. So we talked about scoliosis. There's another condition that can affect the spine, and that is kyphosis, and that's in the upper back, almost like I would say a humpback. There are also some congenital abnormalities that can cause this wedge shape, so meaning the person was born with it. Hemivertebrae is one of the conditions. It occurs when part of that vertebrae doesn't actually fully develop, and that can actually contribute to what we consider an abnormal spinal curvature as well. So a wedge basically just means the front side is shorter than the back side. When we see a wedge, we then have to ask ourselves, or the doctor then has to ask himself or herself, is there trauma involved? Because if there's trauma involved, we might want to think about, is it a compression fracture there as well? In our younger patients, we might need to think about things like Sherman's disease or some type of developmental cause for this wedged appearance. All right, now we're shifting our focus away from the shape of a vertebrae and we're moving into alignment and also stability. So the first case file is on atlantoaxial subluxation. All right, this happens in our C1, C2 area. So we're talking about the C-spine. C1, we call it the atlas, and C2, we call it the axis. This is something that you should have learned in procedures. So when we think about C1, we think of C1 and C2. When we're thinking about this instability, they're becoming too loose or too unstable. And if they're too loose or they're too unstable, they're allowing more movement or head movement than there should actually be for the patient. One way that they look at this or evaluate this, they use the atlantodental interval, or ADI, and this is basically the space between the anterior arch of C1 and the odontoid or the dens of C2. When we when we perform what we call a flexion lateral image, that space should generally be about 3 millimeters or less in adults and about 5 millimeters or less in kids. So if that space becomes too wide, the doctor or a radiologist tends to become worried about joint instability. They think that the joint might be unstable. Now, one of the reasons why this might happen is the structures that normally hold that C1 and C2 together, especially what we call the transverse ligament and also the odontoid, they can be abnormal in some way. They can be weakened or they can also be damaged, causing that instability. There are some probable causes for this. Some patients are born with these conditions that make that area unstable. So a patient that might have Down syndrome or more Morcu, ooh, that's a hard word to pronounce. Morquio syndrome. Those patients might be born with the condition and their head might be unstable. If we have adults that maybe have rheumatoid arthritis, that's another reason that might cause some of this instability due to the chronic inflammation that can weaken the ligament that supports that joint. Trauma can also cause this to happen. It can happen if we have a fracture or some sort of torn ligament there. So the reason we care about this finding so much is that the patient's spinal cord is right behind this area. So if we have too much movement between C1 and C2, that can potentially narrow that space that's available for that patient's spinal cord. So again, atlantoaxial subluxation, we have, or the patient has too much movement between C1 and C2, and they measure that using the ADI measurement, the atlantodental interval measurement. Moving on to the next alignment case file or pattern, and now we're looking at scoliosis. So scoliosis, we simply have the spine appearing abnormal because it has more of a side-to-side curve versus being straight up and down. So if we look at the patient from front to back, if we were to be able to see through their body and look at the spine, it's a side-to-side curve, like almost like an S versus a straight line. So to determine how much that patient's spine is curved, the doctor or radiologist use something called the Cobb angle. And the Cobb angle is basically just a way of putting a number or attaching a number to the curve. The larger the angle, the greater the spinal curvature. Now, the patient's age is also very important when we think about the cause of this. In children and also in teenagers, scoliosis is usually what they call idiopathic. So that basically means we don't know what is actually causing it. It's also typically much more common in girls than boys, and some patients are actually born with abnormal vertebrae, such as with that hemivertebrae, where only part of the vertebrae develops, causing the spine to somewhat grow unevenly. If scoliosis develops later, like in adulthood, we start to look at or think about some sort of degenerative changes, so like osteoporosis. The patient also may have had some type of surgery that's starting to cause this, and there's also some other conditions that can cause the spine to start to become uneven as well. Another thing to think about is that not every curved spine starts with a problem in the spine itself. Sometimes a leg length discrepancy, which I have one due to I broke my leg as a kid. I got hit by a car. Leg length discrepancy, meaning one of the legs is longer than the other one. That difference can start to tilt the patient's pelvis, and it can also start to have an effect on the patient's spinal curvature as well, because it's trying to compensate. Things like muscle spasms from pain can also temporarily pull the spine to one side. One unusual clue in terms of scoliosis is if the patient has what we consider painful scoliosis, especially when we have a younger patient. Now, that one, if they're having what we call painful scoliosis, we should consider, or the doctor might consider, some sort of osteoma, like osteoid osteoma, which is considered to be a bone tumor, typically a benign bone tumor, typically a small bone tumor, but it does cause some pain. Now, with imaging, we might not be able to see or truly appreciate this tumor on a regular x-ray film, so that patient may need some more advanced imaging like CT to actually see and appreciate the lesion. We typically are not going to be able to appreciate it with this just a diagnostic x-ray. So again, if we see a side to side or sideways curve like an S, it doesn't necessarily mean that they have scoliosis per se, has to reach a certain angle. They are going to measure it using the Cobb angle. And again, one of the things that they're going to take into consideration is the patient's age, and they're also going to look for what might be causing that spine to start to curve. Now we're looking at bony outgrowths of the spine. So we're basically talking about that there's some sort of extra bone that's starting to grow along the edges of the patient's vertebrae. An important thing to, I guess, remember is that not all bony outgrowths are going to mean the same thing. Now, their shape and basically the way that they connect to the patient's vertebrae is going to give the doctor a clue about what type of disease might be causing these spinal changes. So there's two terms that are here in the slide that you need to know. One is osteophyte. That's commonly called a bone spur, and they are usually associated with some sort of wear and tear or degenerative change in the spine. The other term that you need to be familiar with is syndesmophyte. Syndesmophyte. With your syndesmophyte, it's a little bit different, and this is what we call a new bone growth, and it's developing along the outer portion of the disc, and it will, what they call, eventually bridge one vertebrae to the next vertebrae. So there are some conditions that are associated with these. Typically, they're associated with inflammatory type conditions. For example, ankylosing spondylitis produces this type syndesmophyte that can, like I said, bridge the vertebrae together. When this happens, when this bridge happens, especially if it happens at multiple levels, the patient's spine can start to develop or look like a bamboo spine or have a bamboo spine appearance. Another thing to consider with these bony outgrowths is something called DISH, or diffuse idiopathic skeletal hyperhidrosis. All right, this looks a little bit different. So instead of a thin bridge, they're looking at, or they see more of a thick flowing bone formation, and it's usually along the front of several of the patient's vertebrae. So it's almost like if you are looking at, if you have a candle, like one of those tall candlestick type candles, and it starts to melt as the wax starts flowing down the front side of the spine, that's what we're talking about when we're talking about DISH. All right, another condition is psoriatic arthritis and also reactive arthritis. They can also produce these bony bridges, but they usually tend to be a lot thicker. They tend to be less complete, and they tend to be a lot rougher as well. So again, when we see an extra bone or extra bone on a spine image, they can be a bone spur, or they can be considered a bone spur. So again, we want to ask ourselves, is it thin or is it thick? We want to ask ourselves, is it completely bridging the vertebrae. And another thing we want to consider is where that new bone is located. All of that's going to give us a clue and potentially help narrow down what the actual cause is. So again, osteophyte is basically more of a wear and tear type bone spur, and syndesmophyte is more of an inflammatory type bone bridge. If we're seeing thin, complete bridges, we're looking more so at ankylosing spondylitis. If we're looking at thick, flowing bone, we're looking at that dish again, diffuse idiopathic skeletal hyperaltosis. Now we're moving on to calcification of the intervertebral disc. So I do want to reflect back, and this is something again that you learned in procedures. The discs are basically cushions that sit between our individual vertebrae or the spine bones. Normally, we should not see any type of calcium building up inside of those cushions. So when a disc does actually become calcified on an X-ray image, it will look or appear whiter or more radiopaque on the image. Now, the first thing that the doctor or the radiologist considers when they're seeing this type of calcification is the patient's age. In a child, if we're seeing disc calcification, that can actually be temporary, or it may disappear as that patient gets older. In an adult, if we see this and it starts to persist, we commonly associate that with things like degenerative diseases or wear and tear changes on the patient over time. When we also see this calcification, we see a portion of the spine that hasn't been, I'll say, moving like it normally should. So for example, if the vertebrae is fused together congenitally, meaning they were born with that fusion, or surgically, that's going to alter some of the movement of the patient, and it can contribute to some of these calcifications in the disc. Now, there's several diseases here on the slide, but again, we're not trying to memorize all of these. It's a lot to try and remember, but I do want you to pay attention to how many discs are actually involved and also what you're actually seeing on the image. So one important example is with ochronosis. With ochronosis, this is a condition, it's a rare metabolic condition that causes multiple discs throughout the spine to start to become ossified. So if you see extensive calcification involving multiple or many disc levels, especially if we're talking about in an older patient, we want to think about this condition. All right, the bottom line here is if you see disc calcification, that means that there's some sort of calcium that's starting to deposit within the cushions between the vertebrae. In a child, it can be temporary. In adult, again, we're going to start to think about things, degeneration, degenerative disc conditions. We somewhat consider, especially if they're an older patient, there might be decreased movement. The patient might have some sort of previous injury, or there could be some sort of underlying disease process as well. So again, we want to look at the age of the patient. Now we're moving on to narrow intervertebral disc height. So if you can remember that the disc between the vertebral bodies are considered to be the cushions between those vertebrae. So if the cushions become thinner, those vertebral bodies, they get a lot closer to each other. So the distance between them gets shorter. So we see usually a smaller disc space, or we can usually see that smaller disc space on our X-ray image. Now the question is, or the question that the doctor is going to ask, or the radiologist is going to ask is, why is that disc space becoming narrow? There are two possible reasons that our book talks about. That's infection and also some sort of degenerative reason why it's becoming narrow. So with degeneration, think about if you have a couch that has cushions or even your pillow on your bed, think about over time as you sit on that couch or as that you use that pillow, it starts becoming less fluffy and more flattened out over time. So we may see some of this with bone spurs. We might see bone spurs. We might see what we call sclerotic or hardened end plate. So that's the top or the bottom of the disc. We also might see something called a vacuum phenomenon. Now, the vacuum phenomenon is basically means that we have some gas that's collecting inside of that disc. And that gas that's collecting inside of the disc on an X-ray, it looks like a dark area. If we see that, it is tied to or suggests that there's some sort of degeneration happening there. Infection, if we're seeing that, it looks a little bit different. An infection that attacks that disc and also the bones on either side of it, it's going to look a little bit different. So instead of having those nice, smooth vertebral end plates, meaning the top and bottom of the disc, we're going to see things that are poorly defined margins. We might see bone destruction as well. So with that, there may also be some sort of swelling that the patient's having, or they might also have some sort of perispinal mass as well next to the spine. So infection itself typically does not produce that vacuum phenomenon that we see with degeneration. There's several other causes that you see listed here on this slide, and that causes also inflammatory arthritis and also discs that don't develop normally. But again, don't get overwhelmed with this huge list. We're just talking about what a narrow intervertebral disc height is and some possible reasons for that height. So if we're seeing that narrow disc plus gas, the doctor or radiologist might start leaning to degeneration. If they're looking at the narrow disc plus some type of destruction or irregular margin, they start to worry about maybe the patient has some sort of infection. Now we're moving on to paraspinal mass. So just to break that word apart, the prefix para just basically means beside. And of course, we're talking about a spinal, so paraspinal beside the spine, a mass beside the spine. So some sort of abnormal soft tissue mass right next to the patient's spine. So with this paraspinal mass, it doesn't necessarily tell us what exactly that mass is, but it does tell us that there is something abnormal that's happening right beside the spine. So now the doctor has, or the radiologist has to go look for some additional clues. So one possible cause might be some sort of infection, maybe TB. That's an infection that the patient can have that can involve the vertebrae and the disc, and also the can spread to the surrounding tissues. Sometimes with that, it can form an abscess as well. So if we see a paraspinal mass, along with some sort of bone destruction or some sort of narrowing of the disc space, infection might be one of the first things that they start to think about or start to point to. A mass could also represent a tumor. It can represent enlarged lymph nodes, and it can also represent bleeding from some sort of trauma. So this is why we can't always, I'll say, assume that every paraspinal mass is related to some sort of infection. Now, there's an important thing that can look like a mass, but it's actually not a mass. It's actually a blood vessel, and that is your abdominal aortic aneurysm. If the patient is having an abdominal or has an abdominal aortic aneurysm, we'll just abbreviate that AAA. This is what we call an abnormal enlargement of that patient's aorta. So on an X-ray, with that we can we might see what we call a thin, not what we call, we might see a thin curved line of calcium, basically outlining that enlarged vessel. It's usually somewhere around L2 through L4 if we're seeing it. Now, this is an important finding because what can happen is, or what appears as a mass beside the lumbar spine can actually be an enlarged aorta. So again, there's a lot of conditions here and we're not trying to memorize them, but we do want to, when you're looking at this mass, you want to start to think about what that mass is sitting beside, what it's sitting beside. You also want to think about, is the patient, or is there infection within the patient? Is there trauma? Has the patient had trauma? Is it a tumor? And then also it could be, again, that enlarged blood vessel, the abdominal aortic aneurysm. Right? So paraspinal, basically it's beside the spine. The mass plus some sort of damaged vertebrae or disc, we want to think about or point to a tumor or maybe some sort of infection. A mass plus trauma, that might be a hematoma or some sort of bleeding. If we're seeing some sort of calcification around the area of L2 and L4, we might want to think about an aortic aneurysm, abdominal aortic aneurysm to be specific. Now we're moving on to SI joint disease. So basically the SI joints are where the sacrum actually connects to the right and left sides of our pelvis or the patient's pelvis. So the easiest way for us to look at this, because as you can see there's a lot of conditions here, we want to look at which SI joint is affected. The doctor or radiologist might ask, are both sides involved equally, or are both involved but differently, or is only one side involved? Now that pattern is going to give them a clue as to what condition might be happening within the patient. If both SI joints look abnormal in a similar, I'll say symmetrical way on both sides, one of the major things that they might point toward or that might lead them to is ankylosing spondylitis. So with ankylosing spondylitis, the infection or inflammation, not infection, on both SI joints is one of the early findings of ankylosing spondylitis. As it starts to progress, you'll start to see that the patient's joints usually will eventually become a lot more narrow, and also they'll start to fuse together. Now, if both sides are involved, but they somewhat look different, they're not symmetrical, they might start thinking about other conditions like psoriatic arthritis or also reactive arthritis. If we're seeing an abnormality that's only on one side, they might start to think about maybe some type of infection. So an example would be that TB, and another would be some other sort of bacterial infection that is affecting that SI joint area and also causing destruction in that SI joint area. Gout and osteoarthritis can also have this one-sided finding as well. Another condition is osteitis condensans. That is a condition. Now, it is a complicated name, very difficult to explain, but it's typically a benign condition. It's a benign area where they're seeing an increased bone density right next to the SI joints. Usually, sometimes we see this, or they might see this in a lot of women that are of childbearing age. Another clue is when they're looking at these conditions is your SI joint space. With this one, it's always preserved or looks normal. So again, when we're looking at SI joint diseases, we're looking for symmetry, or we're looking for asymmetry, meaning not symmetrical, or we're looking for it to be one-sided or unilateral. That's going to help the doctor or radiologist narrow down what might be causing that SI joint disease. So if both sides are involved and they look the same or look symmetric, again, it kind of leads us to or points to ankylosing spondylitis. If both sides are involved but it doesn't look symmetric, meaning it's uneven, they sometimes start looking towards psoriatic or reactive arthritis. And then if it's one-sided, they start looking at, maybe infection being the cause first. Now we're moving on to vertebral end plate alteration. So if you can remember, end plates are basically considered to be the top and the bottom surface of the patient's vertebral bodies or our vertebral bodies. So right next to these end plates sit right next to that intervertebral disc or that cushion. All right, so the main idea with the end plate here, it's looking or starts to look what we consider abnormal. So with that, they want to start paying attention to what kind of change are they seeing. Is it abnormal? Okay, if we say yes, it's abnormal. Is there some sort of defect or indentation, or is part of the bone becoming separated? Those two appearances can lead the doctor to what the possible condition is for the patient. So one common finding when we're talking about limbus vertebrae, and when we talk about limbus vertebrae, we're just basically talking about there's a bit of separated bone that we're seeing. It's happening when a small piece of that vertebral edge becomes separated during development. So on an x-ray, it can look like a little bone fragment. So a clue is that that piece of bone is usually very smooth, meaning it's pretty nice and finished border. So it tells us that it's an older developmental type finding rather than something that's brand new or a fracture. Another common finding is the Smurl node. With the Smurl mode, if you can Smurl node, geez, if you can remember. This happens when we have some sort of soft material from the disc being or pushing up and down on that vertebral body through the end plate. So again, think of the disc as basically making a little dent in the bone. When we see some of these end plate changes, we start to think about Sherman's disease, especially when there's multiple nodes along the wedging of that vertebrae. So again, don't look at this list and get overwhelmed. When we see an abnormal end plate, simply they're gonna want to know, what does the edge actually look like? They're also thinking about, is it an old fragment or is it a newer condition? They're looking at the indentation from the actual disc. They're also looking at irregularities that can suggest what type of disease process is happening. So again, limbus vertebrae, we're having the little piece of bone actually separated away. And then with the Smurl node, that's basically, we see that the disc is pushing into the bone. Next two slides, we're going to be covering osteolytic lesions of the spine. So when we talk about osteolytic, we're basically saying that the bone is somehow being destroyed or something is eating away at the bone. So if we're seeing this on an x-ray, it's typically going to be areas that appear darker than the surrounding, I'll say, normal bone. So with these types of lesions, one of the first things that the doctor or radiologist asks themselves is, where is the vertebrae lesion actually located? So location can actually help them narrow down some of the possibilities. If that lesion is mainly in the vertebral body, conditions like multiple myeloma, infection, hemangioma, and also metastatic disease might be some of the possibilities. If it involves what we call posterior elements like the neural arch or the transverse process, they might start thinking about some different groups or possibilities. So again, there's also some what we'll consider helpful appearances that we can recognize. One is hemangioma, which is usually a benign collection of blood, abnormal blood vessels in the bone. If we're seeing this, it can produce what we call a gel bar appearance. Infection also tends to cause what we call poorly defined bone destruction, and it also may cause disc space narrowing as well. Or it also might cause some sort of soft tissue mass. With our metastatic diseases, they will appear or produce what we call moth-eaten areas of bone destruction. So basically, like a moth eats away at clothes and causes holes, we're seeing that type of destruction going on. All right. Now, multiple myeloma, we talked about that earlier. Multiple myeloma affects or can affect the vertebrae. It can affect the legs, the arms, the pelvis, and also the skull and ribs. So when we're seeing that condition, it looks like or produces what we call lytic lesions or punched out areas, a lot of them. So again, when we see a lytic lesion, we're not just looking at the lesion itself. They're looking at the location, they're looking at the borders, and they're also looking at what other things are surrounding that bone and also disc spaces as well. That's going to give them clues as to what condition is actually causing it. So again, osteo is bone, and lytic is destruction of the bone or that bone being lost. So this slide is still focused on osteolytic lesions, meaning that these conditions basically are causing some sort of bone condition. Now, these are the more or less common causes, but again, we're not trying to memorize all of them because there is a pretty good list of them that are on this slide. But it is important when they're looking at these, they're going to be one good clue or big clue is the location. All right, a lot of these less common lesions tend to involve the posterior parts of our vertebrae, such as the neural arch and also the transverse process, or they can also or may also involve the sacrum. So you learned about these parts of the vertebrae, hopefully in your procedures class. With your aneurysmal bone cyst, that's usually seen in younger patients. Typically, those patients are under the age of 20. It is benign, but it can expand the bone and it can actually cause a lot of pain for the patient. With osteoblastomas, also benign, they commonly involve also the posterior portions of the vertebrae, and they can look very expansive as they continue to grow, so very large as they continue to grow. With giant cell tumors, that's another destructive lesion that the patient can have. In the spine, it has a tendency to start involving the sacrum. So another one that you want to remember that we talked about a couple times is eosinophilic granuloma. It doesn't commonly involve the spine, but if it does involve the spine, it can actually cause the patient's vertebral bodies to start to collapse. And that collapse is a dramatic collapse. Basically, it's going to flatten out the vertebrae. It's called vertebral plana, flatten out like a pancake, a flat pancake. All right, so again, when we're looking at these less common causes of bone destruction, we want to know still, where's that lesion at? What's the patient's age? Whether or not the bone is expanding or whether or not the bone is collapsing. And all of that can help us narrow down to what that patient's condition might be. All right, now we're moving on to ivory vertebrae. So this is almost the opposite of those osteolytic lesions. So instead of losing bone density and it appearing darker on the x-ray with ivory vertebrae, it's showing us or appears as a more dense or wider area on our x-ray, whiter, not wider. So think of it as like one vertebral body that starts to look a lot wider or brighter on the x-ray than the other vertebral body. So when we see this appearance, or when the radiologist sees this appearance, there can be three causes of this appearance. It can be osteoblastic. It can be, when we say osteoblastic, we're talking about some sort of metastasis. It can be Paget's disease, or it can be a lymphoma or lymphoma. With osteoblastic Mets, we're talking about a cancer, and that cancer is starting to spread throughout the bone. And it also, when it's spreading throughout the bone, it's going to stimulate some sort of abnormal bone production for the patient. We see this sometimes with breast cancer and also our prostate cancer patients. Those are primary cancers, and they can produce this ivory vertebrae, or this dense appearance of a bone. Another condition is Paget's disease, and that can make the vertebrae look more dense. Again, it's often also causes the vertebrae to become, if we're talking about Paget's, a lot larger and thickened around the edges. So remember that picture frame vertebrae appearance. Around the edges, it's a lot thicker. The lymphoma, typically we're talking about Hodgkin's lymphoma. It can also produce this ivory vertebrae, but the vertebrae itself, usually in terms of its size, it stays its normal size. So again, there's several conditions. Some of them are less common, and they're, again, they will cause this whiter or brighter pattern or appearance. Now we're moving on to radiodense vertebral stripe. So we're basically talking about there's some sort of increased bone density. So by the time we actually see this, the entire vertebrae itself, it's not white like the ivory vertebrae that we talked about earlier. Instead, we're seeing this on an X-ray. It looks like horizontal white bands or white stripes that are running across the patient's vertebral body. Now, the location and appearance of the stripes will give the doctor clues about what it could be. One of the patterns is a rugged jersey spine, and that's associated with hyperparathyroidism. Usually, when we're seeing this, the top and the bottom portions of that vertebral body become more dense, and that is going to be creating what we call those white bands. And in the center is going to be a little bit darker, so it creates like a striped appearance, like the stripes that we might see on some sort of player's jersey. Now, when we see osteopetrosis, these bands tend to be a lot sharper and very well defined. With this one, it can produce what we call a sandwich vertebrae, all right, because the dense top and the dense bottom make the vertebrae look somewhat like a layer or the layers on a sandwich. We can also see some of these dense bands after the patient has some type of compression fracture. When the vertebrae is compressed, the bone gets packed together at that injury site, and it's going to create a wider area called that wider area is called the zone of condensation. So again, the main thing that we want to look at or recognize when we're talking about the pattern, the ivory vertebrae, if we're seeing that, that means that whole vertebral body becomes uniform in the color or density, and we're looking at it as brighter or whiter on the image. With the radiodense stripes, that means that we're seeing a specific portion or a horizontal band of some sort of increased density across the bone. So again, the appearance and the location of the bands are going to help determine where the disease process is coming from. So the rugged jersey, again, we're looking at hyperparathyroidism. With the sandwich vertebrae, we're looking at osteopetrosis. So again, dark bands after injury, if we're seeing those, we're going to be thinking about, or the radiologist will be thinking about, maybe there's some sort of compression fracture. All right, on our next two slides, we're going to be looking at diminished vertebral height. So basically, we're saying that the vertebral body itself isn't normal in terms of its height. It's lost some of that normal height. So sometimes we call it collapse. All right, when we think about the vertebrae itself, we're thinking about it being that block or that square. So normally it should maintain its height. If the height is compressed, or if the vertebrae gets compressed or weakened or even destroyed, the height starts to, I'll say, diminish. It starts to squish down and it starts to get shorter. So one of the most common reasons for a loss in height is the patient might have a compression fracture, especially in patients that have osteoporosis. They might have a compression fracture. Mainly, the front of that vertebral collapse, if we're seeing a collapse, it starts to become more like a wedge shape. And we talked about that wedge shape a little bit earlier. Fractures themselves aren't the only cause of vertebral height loss. Infection can cause this. Multiple myeloma can cause this, and also MET can cause it. Metastatic cancer can cause this. And usually the cause is because that bone starts to either weaken or be destroyed in some kind of way. And that destruction is enough to cause the vertebrae to lose some of its height. Another clue when we're looking at the vertebral height, they're also going to be looking at that disc space as well. Now, when we're talking about infection, it can damage other discs that are nearby, and it can also cause the space to actually start to, I'll say, narrow, all right, not be as wide as it normally would be. So again, these are some of the things that we're looking at for disc height. If we see what we call a dramatic vertebral collapse, we will call that a vertebral plana. Plana means basically it became flat. So that vertebral body becomes extremely flattened out, almost like a pancake or a wafer. A classic, I'll say, cause of this collapse can be eosinophilic granuloma, specifically when we're talking about children. If we're looking at Sherman's disease, it can also cause this decrease in vertebral body height, but instead of just one of the vertebrae suddenly starting to collapse or suddenly collapsing, we typically are going to see that interior wedging of a few of the vertebrae or several vertebrae. And when we see this, it can contribute to or cause the patient to have kyphosis. So basically like that humpback appearance that we talked about earlier. All right, so when we see decreased vertebral height, it's not always going to point to a fracture. Some of the things that they're going to want to know is it just one vertebrae or is it more than one vertebrae? They're also going to want to know if it is completely flattened or if it's wedged. And they're also going to look to see if there's any type of disc space involved in that loss of vertebral height. All right, we're still looking at vertebral height, but now we're looking at some of the less common causes of that loss of height. Again, a pretty large list of conditions here, so we're not trying to memorize them, but these are some of the things that can cause the loss of the vertebral height. So basically with the loss of height, we already know that something has weakened that patient's vertebral body, and it's weakened it to the point that it has lost some height. So it could be a tumor, it could be some sort of bone disorder, it could be some sort of blood supply issue, or it can be another disease that actually causes that loss of height. All right, we can also see a collapse when the patient has some sort of bone tumor, a benign bone tumor. It will potentially weaken the vertebrae enough to cause what we call a pathologic fracture, and that's a fracture that basically means that the bone broke because it was already weakened by the disease process that was happening within the patient. Some other conditions that you might recognize from earlier might be sickle cell disease. We already know it can produce that H-shaped vertebrae because the center of those end plates become depressed. There are other developmental conditions that can cause this loss of height. Eosinophilic granuloma can produce that flattened vertebrae, the vertebra plana. So again, we're not trying to memorize all of these. Another one is Kumel disease. With Kumel disease, this is more of a delayed vertebral collapse after the patient has some sort of injury. So with that trauma, you'll eventually see that the vertebrae will start to collapse. And with that one, if we're imaging that one of the clues that the radiologist looks at is a vacuum sign inside of the vertebrae, meaning that they can actually see that there's gas within that collapsed vertebrae. So again, not trying to memorize all of these, but when we're looking at that loss in height or that vertebral collapse, we're looking at, is it one level or is it more than one level? Is there some sort of history of trauma as well? They'll need to know that. Is the bone otherwise abnormal in some other way? And all of these things are going to give the doctor some sort of clue of what might have caused this loss of height. All right, so this is going back to the strategy that we learned of how we're going to look at these spinal patterns. Again, there were a ton of different diseases, so there's no way for us to memorize all of them, know them per se, because again, we're not in the business of diagnosing, but we do want to have a general idea of what normal looks like and what abnormal looks like. So first thing we're going to do is, or the first thing the doctor might do is look at the distribution. When they're looking at that x-ray finding, is that finding on both sides, meaning is it symmetric? Is it affecting, I'll say, several levels versus one level, or is there only one abnormal vertebrae? Those are some quick clues to help narrow down to what that condition might be. Another thing that they're going to look at is that disc space. If they see what they call that vacuum phenomenon, the gas within the disc, that's usually going to point them towards some sort of degenerative change. But if those disc spaces are also narrowing with bone destruction, or we have some sort of paraspinal mass, it might point them more towards something like infection. All right, another clue might be the pedicles and the posterior portion or the posterior elements. When we look at METs or some sort of metastatic disease that's spreading into other areas, this might be involved. So again, multiple myeloma can help, or not help destroy, but can destroy some of the vertebral bone. But again, it involves more than one vertebral body, and it might spare the posterior elements, but again, that's where some of the clues might be seen. So location helps the doctor or the radiologist kind of separate the conditions apart as well. When I say separate, some of these things might look the same, but depending on the location, it could point to another disease process. The last thing that they're going to do is they're going to take the history into account, and then they're going to also take the patient's age into the account, as well as the level of that spine involved. So certain conditions tend to happen or occur at a specific age range, meaning some happen in very young and some happen in the very old. So again, not trying to memorize all of these, just looking for patterns so that we can see when we get an x-ray and it looks abnormal, we'll be able to identify not necessarily the process, but we can identify that, oh, that doesn't look right, that doesn't look normal. So we might be able to hurry the patient along to their next, maybe advanced imaging that they might need for their diagnosis. We're looking at our quick recognition slides, and this is the first of 3 of them. So again, I'm not trying to memorize this stuff, but we just want to have an idea of what normal is versus abnormal. So if we're seeing that the patient's odontoid has moved too much in terms of higher than it should be, when we're looking at the neck being flexed. If it's more than 5 millimeters, again, if we're talking about a child, and more than 3 millimeters, if we're talking about an adult, we're talking about atlantoaxial subluxation, meaning there's too much movement between C1 and C2. So there's some sort of neck instability there. In a child, if we see a small anterior beak, or if we see posterior scalpeling, or also a narrow spinal canal, it might lead the doctor to the condition of achondroplasia. If we see two vertebrae that are fused together from birth, and the disc space between them is very small or underdeveloped, they might think about congenital block vertebrae. If the SI joints on both sides of the patient are affected symmetrically, along with the patient having bone bridges, thin bone bridges, we might think about syndesmophytes. And if we see that, it will lead them to the condition of ankylosing spondylosis. And last but not least here, when we see calcification in multiple intervertebral discs, that might be onchronosis, that condition of onchronosis. All right. All right, here's our second of 3 quick recognition slides. So if we see one disc space that's narrowed, along with some sort of destruction of nearby bone and also some sort of soft tissue mass next to the spine, the doctor or radiologist might start to be concerned with some sort of infection. So again, that has to be a combination in terms of finding out what is happening with the patient. If the vertebral body has thick vertical lines running through it, sometimes we describe that as a jail bar appearance. So jail bars, if you looked at TV, someone in jail, sometimes you see them behind the bars. That will sometimes lead them to think about vertebral hemangioma, and that is typically benign. It's a collection of abnormal blood vessels within the bone. If the patient is over 40 and you are seeing some sort of uniform white or dense areas, they might consider osteoblastic metastasis, meaning the patient's cancer is starting to spread throughout the bone, and also it can increase some of the bone formations as well. And last but not least, if we're seeing that sandwich type vertebrae, if there's very dense white bands along the top and bottom borders of the vertebrae, almost like a piece of bread or a sandwich, they might start to think about osteopetrosis. So again, when we're looking at these patterns, if we're seeing destruction plus a mass, they might think of infection. Vertical jail bars, hemangioma. If we're seeing that sandwich appearance, they might think about osteopetrosis. And if they're seeing what we consider dense vertebrae, they might consider that there's some sort of metastasis going on, osteoblastic metastasis. All right, this is our last quick recognition group slide. And again, there's a lot of conditions that we went over this week. So if the patient presents and they have painful scoliosis, and we're also seeing on their imaging sclerotic pedicles on the inside of the curve, that might lead the radiologist or doctor to consider osteoid osteoma. And with osteoid osteoma, we're talking about a benign bone tumor. It's a very small bone tumor, but it does cause a lot of pain and also muscle spasms for the patient. It can also eventually contribute to the scoliosis that they're seeing because of those muscle spasms. If the doctor is seeing or you're seeing those punched out lesions, a lot of punched out lesions appearing in the bone, and it kind of looks like some of the bone is missing, that might be given consideration to multiple myeloma. All right, with multiple myeloma, it does attack the vertebral bodies mostly, and it doesn't necessarily mess with the pedicles. If we're seeing a vertebral body that has almost completely collapsed, it's thin like a wafer or a pancake, they might consider the condition vertebra plana. One of the causes of that condition is eosinophilic granuloma, as we talked about earlier. And last but not least, if they're looking at a piece of bone or like a bone fragment at the corner of a vertebral body, it's very well defined. It's, I'll say, an older type of fragment, they might consider limbus vertebrae. So basically, it's not a new fracture. It's like a chronic issue or chronic developmental problem that the patient has. So again, painful scoliosis is osteoid osteoma, or could lead us to that condition. Punched out lesions in the image, multiple myeloma, a pancake flat vertebrae appearance could lead them to the condition of eosinophilic granuloma. And if there's a fragment that's pulled out and is sitting near or adjacent to the vertebrae, they would consider limbus vertebrae. So now we are ending our spine pattern chapter. So there's a lot of conditions that we looked at, a lot of case files that we looked at as well. So again, we're not expecting you to memorize any of these, but there were 4 questions that we started with initially, and these are the questions that the doctor and also the radiologist might ask as well as they're looking at the patient's imaging. Is there something happening with the shape of the vertebrae? If there's not something happening with the shape of the vertebrae, is there something happening with the alignment of the vertebrae? Is it abnormal or normal alignment? Some of the other things that they might be looking at is what's happening to the disc spaces or the surrounding tissues around that vertebrae. And last but not least, is that patient's bone becoming more dense, or is their bone becoming less dense? So if, again, we can identify some of these patterns, the radiologist and the doctor are able to start narrowing down what might be the cause of the patient's condition to get a diagnosis. When we talked about lytic lesions or areas where that bone is being destroyed, do remember that the location of that lesion is going to actually matter. If that abnormality is normally or mainly in the vertebral body, or is it involving the pedicles or some of the posterior elements of the vertebrae, that will help narrow down some of the conditions as well. Another thing to remember is when we're talking about degeneration and infection, is there gas in the disc, or that vacuum phenomenon? That's what we're talking about, gas in the disc. If we're seeing that, usually it's going to point them or lead them towards degeneration. In terms of bone destruction, disc space narrowing, and also paranasal mass, some of these things will lead us to, or lead the doctor to be more concerned about the patient having some sort of infection. So again, these are just some of the clues. As you start taking x-rays every day, you'll know what normal looks like, and you'll know what abnormal looks like when you finally get to see something that is abnormal. So again, we're starting with looking at what the image is actually showing us in terms of the shape, in terms of the alignment, in terms of the disc spaces, in terms of the density, and those patterns alone can help narrow down and guide the radiologist and the doctor to what might be causing the issue with the patient. This is the last chapter that we had for the week. Now we're shifting our focus. We started at skull, then we went into spine. Now we're looking at some of the extremity patterns that we might see. So again, a lot of information that we went over this week, but now we're going to shift our focus and attention to long bones of the arms and also the long bones of the legs. So we're going to look at 9 different patterns when we're talking about extremity patterns. Just like we did with the spine and the skull. Again, we're not trying to memorize these diseases, and we're not even trying to make a diagnosis, but we do want to know what abnormal looks like, what normal looks like, and sometimes we might be curious about what is actually going on. So some of the things that when we see something abnormal in a long bone, we should start thinking about where it is. And we should also actually start thinking about also what is the bone actually doing. For example, if we see some sort of abnormality near the end of the bone, along the shaft of the bone, or is it involving the entire bone? All right, then we'll start to look a little bit deeper as to whether or not the bone is actually being destroyed. Is it becoming more dense? Is it expanding, or is it changing shape, just like we did for the spine and also skull patterns as well? So location, just like the other chapters, location is going to be important. when we're looking at these bone lesions, because some conditions have, I'll say, a favorite place that they would like to be, a favorite place where they occur, a place that they occur more often than others. So as we go through these patterns, again, we're looking at 9. We're going to keep coming back to basically where did the change first occur, and then we're going to look at what changes we're actually seeing. So these are our 9 extremity patterns that we're going to look at today. And again, like I said, we're not trying to memorize all of them. All right, so the first one is acroosteolysis. That basically means that we're actually losing or reabsorbing bone at the fingertips. Another category is calcified loose bodies. These are small pieces of calcified material that's sitting inside or around a joint. We have epiphyseal changes, usually involving the end of a long bone, where we may notice an abnormal size change or an abnormal shape change. Then we have 2 patterns that we can both look like, in terms of the bone, they can both look like holes in the bone. We have cystic lesions, and we also have aggressive osteolytic lesions. The difference is that cystic lesions tend to look more contained, while the osteolytic lesions, the aggressive ones, they tend to be more destructive to the bone. We have osteosclerotic lesions. They go in the opposite direction, so the bone becomes wider or more dense. We have periosteal reactions. They involve the bone's outer covering, the periosteum. It's reacting by producing more bone. And last but not least, we have metaphyseal bands. So these are lines near the growing ends of a long bone, and they may be more radiodense, meaning they're wider on the image, or they may be more radiolucent, meaning they appear darker on the image. So we're not going to necessarily start with the disease names. We're going to start with these patterns, and we're going to start with the questions of where that abnormality is happening in the bone, and actually what is actually happening to the bone as a result of that abnormality that we're seeing. All right, so we have 9 patterns, and we have 4 buckets, and we also have our analogy here. All right, so this is how we're going to organize the extremity patterns that we're going to go over today. So we're going to think about that long bone like a construction site, is what this slide said. So when we look at the patient's x-ray, we're basically going to be asking which part of the construction process has gone wrong. And this is the same thing that we did earlier on in the semester or term when we looked at the congenital defects and some of the other conditions that and the arthritic changes, etc. So first, a hole can open up in the bone, and this gives us a clue to some of the lytic or cystic type appearances. Then we're going to ask, does it look like it's growing slow, or it's well contained, or does it look like it's very aggressive and very destructive? All right, so that's the first thing that we're going to think about. The second thing we're going to think about is in terms of material, the bone can actually put out too much material per se. So instead of the bone losing mineralization, or meaning we're thinking about osteoporosis type conditions, instead of the bone losing mineral or material, we're going to see that that area is becoming more dense or wider. And that may be due to more sclerotic type lesions or a dense metaphyseal band. The third thing that we're going to look at is the bone. The bone can react to different things around it. So what is happening to the bone? So the periosteum, which is the outer covering of the bone, it might start producing new bone in response to some type of irritation, or some type of injury or infection, or even another disease process. It can have this response. When we see This response, they typically call it a periosteal reaction. We might also see some loose material develop within the patient's joints as well. And then the fourth thing that we're going to look at is we can have a problem that involves basically the growing end of the bone. So that's why the metaphysis, the epiphysis, and also even the fingertips can give us a clue as to some of the growth or metabolic disorders. So again, as we're looking over the 9 patterns that we saw earlier, we're going to keep these 4 buckets, or I'll say questions per se, in mind. Is that bone being lost? Is too much bone being produced? Is the bone actually reacting to something, or is there some sort of problem with the growth in general of the bone? That's going to help us sort out some of these conditions or diseases. Now we're combining those 4 questions with the 9 extremity patterns that we talked about earlier. So this is how we're going to decide what kind of abnormality we're looking at. So the first one, is there a hole in the bone? If there is a hole in the bone, we're thinking about whether it's cystic or whether it's osteolytic in terms of lesions. Then we have to decide, or the radiologist or doctor has to decide, does it look like it's growing very slow and it's well contained, or is it looking more aggressive and destructive in nature? All right, the second category there is there too much bone? So if the bone, when we're looking at it on an image, if it looks unusually white or unusually dense, we tend to, or the radiologist or doctor may tend to lean towards sclerotic lesions or some sort of dense metaphyseal band. All right, the third question or pattern there, is the bone reacting to something? So the periosteum may lay down new bone or start to build new bone, or calcified material can actually collect inside of a joint. So if we're seeing these type of findings, it tells the radiologist or the doctor that the body might be responding to some sort of underlying problem that the patient might be having. Last but not least, when we're looking at the fourth category, or the fourth question, is the growing end of the bone changing? So is the epiphysis, is the metaphysis or metaphysis, epiphysis, metaphysis, and also they're looking at fingertips. So these are where we can see growth-related problems. Also, as areas where we can see sometimes bone resorption may result or may show up in those areas first. So again, these are the 4 questions with the 9 categories layered in. And again, we're looking at whether or not there's a hole, whether or not there's too much bone, if the bone is reacting to something, and whether or not it is the growing end is abnormal. All right, here's some mnemonics that they use when they're looking at some of the extremity patterns. All right, so the first mnemonic there is phlegmomassic. All right, phlegmomassic is the acronym, and it's basically a memory tool that they use to I'll say identify some of the different causes of the lytic lesions and also the cystic lesions that are happening in the patient's extremities. The main point is that a lot of these different conditions can appear or create those dark or hollow looking areas in the bone. So this is just an acronym that spells out that big list that you see right there of conditions that can show or cause cystic and lytic lesions. All right, the next, when we're looking at cystic rib lesions, there's another mnemonic there, FAIN, which helps them remember fibrous dysplasia, aneurysmal bone cyst, metastatic disease, or myeloma, and enchondroma as well. So these are in terms of cystic rib lesions, these are the conditions that could cause it. The next mnemonic that we see right there is lemon. and that is for when we're looking at round cell cystic lesions in the shaft of a long bone. And this includes the things that can cause it are leukemia, lymphoma, eosinophilic granuloma, Ewing tumor, neuroblastoma, metastasis, osteomyelitis, and multiple myeloma. So all of those conditions in that order make up the acronym LEMON. All right. This particular slide, or these keys right here that we're looking at, it also helps us with some reading clues. Not that we're reading it, but we're interested, hopefully, in the patient. Some reading clues. So first, when the doctor or the radiologist is looking at the imaging, they're looking at the margin, or what they consider a zone of transition, and that's the basically we're talking about between the lesion and what we consider normal bone. So if that border is sharp and narrow, that lesion is considered to usually be growing a little bit more slower and contained, and most often, or more likely, the lesion might be benign. Of course, there's more that goes into just saying it's benign. There's more testing that has to be done, but if we're looking at that border and it appears wide and fuzzy in appearance, and the borders aren't well defined, they typically consider or classify those lesions as being more aggressive, and possibly more malignant as well. The next thing they're looking at what they consider a periosteal reaction. So we have a thick, smooth reaction. Usually when we're seeing that reaction, it usually suggests that there's a slow process happening. When we have a more spiculated or layered or interrupted type reaction, it usually suggests that there's something more aggressive that's happening within the patient. So again, the big takeaway for this particular slide in terms of reading, even though we're not reading, in terms of memorizing things, we're not just we don't just ask what the lesion is. They also have to look at the borders. They have to look at how that bone is reacting to what's happening to it, and those two clues, along with all of these other mnemonics, will help tell whether or how aggressive that process is that's happening within the patient. All right, this is our first case file for our extremity patterns, and we're looking at acroosteolysis. So that basically means that the bone at the tips of the patient's fingers or the tips of the patient's toes is somewhat being eaten away or resorbed. When we're looking at it on an x-ray, the very end of the distal phalanx might look a little bit shortened. It might even look partially like it's missing, or it might look tapered off. There's several reasons why this acroosteolysis might happen. But again, as you see, this is a huge list right here. We're not trying to memorize it, but some of the things that might be familiar that you might have seen in the past is hyperparathyroidism, psoriatic arthritis, sclerodoma. There might be some nerve-related diseases, and also severe cold or burn injuries can also cause this condition to happen. So one clue in terms of these patterns is when the patient has hyperparathyroidism, we might see, or the doctor might see, some resorption of the distal tufts, or of some of the, when we're talking about the bone changes. With psoriatic arthritis, the fingertips might look a little bit tapered or irregular in appearance, and then with sclerodoma, the soft tissues might also start becoming calcified or thin. So when we're talking about, because we said severe cold and burn can cause this injury as well. So frostbite is a condition when you're exposed to extreme cold. Sometimes, or typically, it might be seen or happen at the fingertips. So the fingertips of the patient might be damaged as a result of the loss of the blood flow as a result of frostbite. So one of the teaching points is that in terms of when we're looking at this, the thumb might be, I'll say spared because it's usually protected inside of, when we're cold and we start clenching our hands in our fists, the thumb is usually protected when we're seeing that. So the main takeaways when we're talking about acrosteolysis, it means that there's some type of loss in bone at the ends of the fingers or at the ends of the patient's toes. Usually we have to couple this loss with some type of, if we're seeing this pattern, has to be some type of patient history as well, in addition to the findings that they're seeing on the imaging. Our next case file we're looking at is calcified intra-articular loose bodies. So we're talking about there's small pieces of calcified materials that's floating inside of the patient's joint. So we often see this in some of our, I'll say, larger weight-bearing joints like the knee joint. But again, this is some of the joint reactions. So when we're looking at the loose bodies, they can come from several things, as you can see here on the right side in the purple box. One of the most common causes, or a common cause, is DJD, so degenerative joint disease. With that, there will be pieces of cartilage or bone that can break loose as that joint is starting to wear down. Trauma can also create these fragments after some type of injury that the patient has. We can see these fragments there as well. Sometimes the patient might not even know that these fragments are there. Other times, those loose bodies, as they're moving around inside of the joint, they can cause things like clicking, catching, even locking of that joint sometimes, and then they can also cause pain as well. Another condition is osteochondritis dissecans, and that can also cause a piece of the cartilage and bone to basically become loose or separate from the joint. Another cause is osteochondromatosis, and that's where we'll see several cartilage, I'll say, nodules form in the joint lining. And then they calcify, and after they calcify, they might break away. So again, when we're looking at calcified interarticular loose bodies, these are, again, small fragments that we're seeing inside of the joint. If they do become calcified, we are then able to see these on the patient's x-ray, and some of these calcifications can cause that joint to catch or lock up, and it can also cause pain for the patient. The next extremity pattern appears as a change in the size or the shape of the epiphysis. All right, so if you can remember, if you go back to your anatomy and physiology class, the epiphysis is at the end of a long bone, so right next to the joint. When that epiphysis looks too small, when it's irregular, when it's dense or unusually dense, when it's fragmented or flattened, we start having to ask ourselves, or the doctor starts having to ask, what causes this this appearance when it starts to look that way. They also might want to know what is also affected as a result, because sometimes blood supply, development, and also growth can be affected as a result of an irregular epiphysis. So one of the major causes, and some of you presented this in either this week or last week's presentation, one major cause is avascular necrosis. So this is what happened. This is what can happen as a result of avascular necrosis. So that basically means that with avascular necrosis, that the patient's bone is not getting enough blood supply, and it eventually dies as a result. So depending on which joint is involved, the process will have different names. So if it's happening in the hip, they call it leg calviparous disease. If it's happening in the metatarsals, the heads of the metatarsals, it's called Freiberg disease. And in other joints, there are some other names that it's called. But again, the major cause of these changes in the size and the shape is avascular necrosis. Now, there are some other congenital and metabolic diseases, congenital meaning they were born with it, that can happen that make that epiphysis look abnormal. But again, as you can see, there's a long list there. We're not trying to memorize it. We just want to be able to recognize what an abnormal epiphysis means in terms of something or what has affected that growing end of the bone. So again, as the radiologists or doctors looking at this imaging, they're looking at that end of the bone and they're asking themselves, basically, is it the right size? Is it the right shape? Is it the right density? They're also looking at things like if it's fragmented, if it's flattened, or if it's unusually dense. And then they couple that also with other things like, is it causing a problem with the blood supply? Is it a result of clinically, if they present it as a result of some type of trauma, or is it a result of some type of abnormal development? On the next couple of slides, we're going to look at cystic lesions of extremities and also the ribs. We're going to look at the more common causes that you see on this slide, and then on the next slide, we're going to look at the least common causes. So when we're talking about cystic lesions, if we're looking at these on the x-ray, we'll see areas in the bone that look dark or they'll look hollow. In terms of a cystic lesion, again, it's a spot where the normal solid bone has been, I'll say, replaced by something else less dense. Sometimes that's a fluid, or it can also be a softer tissue. Now, as you know, as the x-rays pass through that area more easily because it's less dense, it's going to look darker than that surrounding bone, just like air appears versus how bone appears. Air appears darker. One of the important things about the cystic lesion is the border. So a cystic lesion will often have what they consider a smooth, clear edge or clear border, well-defined border, and that tells the doctor or the radiologist that whatever is there is growing a lot more slower, and the bone is having time to somewhat form a boundary around whatever is foreign or whatever is attacking it. When we're talking about an aggressive osteolytic type lesion, that's also destroying the bone itself, it's going to look dark, but the edges itself are going to be what they call fuzzy. They're not well defined, they're kind of irregular, and that's because it's destroying that bone a whole lot faster. So again, cystic lesions look like dark spots or holes in the bone, and they're usually going to be smooth. They're going to have well-defined borders. They're going to be well contained, whereas osteolytic aggressive lesions are not well contained per se. Now, the first thing they're going to look at when they're looking at cystic lesions is they want to know or look at the location, because where that lesion sits can help narrow down what the possibilities are for the patient's diagnosis. If that lesion is near the epiphysis or the end of the bone, they tend to gravitate more towards thinking of things like giant cell tumor or a subchondral cyst, even could be an infection, or chondroblastoma. Another, I'll say a few common examples that from this list that are worth taking a deeper look at are enchondroma. That's a benign tumor of the cartilage. It's typically found in the hands and the feet of the patient. And also, they might have some small calcifications in it. Another thing is a non-ossifying fibroma. That one is benign. It's commonly seen in our younger patients, usually around their knee area. And then we have fibrous dysplasia. And when we're looking at that, it has what they call a classic ground glass appearance. And then we can also have a simple bone cyst as well. That's usually seen in younger patients as well, usually in the upper humerus or their femur area. So again, when they're looking at these lesions, they're asking themselves, is it well defined? meaning slow growing. Is that dark area well defined? They're asking how old the patient is, where it's located, what the borders look like. Is it contained? Is it not contained? That's going to be able to give them clues on whether or not it's a benign cystic lesion or something way more aggressive than that. All right, and this is our slide on the least common causes of cystic lesions of our extremities and ribs. So one of the ways that they approach this or look at this is when they're looking at these lesions, they also want to look at the patient's age and again, the location, where's the lesion located. Typically, when the patients are younger than age 30, they start looking at things like bone cysts, a simple bone cyst. They look at non-ossifying fibromas, eosinophilic granulomas, aneurysmal bone cysts, and also they look at chondroblastomas as well. That word non-ossifying just basically means that it's not turning into bone or not appearing like bone is. So ossify means to form bone, so non-ossify means it's not forming normal bone per se. Now, some of the lesions, again, they have a favorite place or a favorite location that they like to gather in. So our giant cell tumors, they're typically found near some sort of joint, especially around the knee. Your chondroblastomas, they usually involve the epiphysis, especially in younger patients. And your aneurysmal bone cysts, they tend to be or look very blown out or enlarged, meaning it can make the bone look blown out or enlarged because it's expanding. All right, so again, there's a huge list here, and there was a pretty good list on the last slide for what causes or can cause or result in cystic lesions of the extremities and the ribs. So again, some of the things that they take into consideration to include the imaging piece is how the patient is, where that bone lesion decided to format, where it's gathering, if it's well defined, slow growing, or if it's aggressive, and also is the bone actually expanding or getting larger as a result of that lesion. So that can kind of give the doctor or radiologist an idea of some of the things that they should consider, and it can narrow down the list for them. Now we're going to take a look at aggressive osteolytic lesions, and these are basically going to be seen as areas of the bone that are being destroyed pretty quickly. So instead of it being a smooth, well-defined border, the edges of those lesions are going to be fuzzy. They might look pretty moth-eaten out, so they are acting really aggressively. In terms of appearance, it is important to be able to tell how the process is behaving, if it's behaving aggressive or if it's not behaving aggressive per se. And the reasons why is because some of the causes of this can include infection. It can include things like malignant bone tumors, Ewing sarcoma, lymphoma, multiple myeloma, and also metastatic disease. So one of the clues when they're looking at these osteolytic lesions, they're looking at the periosteal reaction. So aggressive lesions tend to cause or might cause the periosteum to react in a more, I'll say, interrupted or layered pattern. They call it somewhat an onion skin pattern. So with Ewing sarcoma, if you've ever looked at an image of that, or if you find that in your book, it says that it can produce a onion skin type appearance, and that's basically where that new bone is trying to form several layers around the issue or the lesion. So we also said infection can cause these lesions. So it can look pretty similar to what we would sometimes deem or call a tumor. So we have to look at things like, is the patient in pain? in that area. They're looking at the clinical history. They're also looking at the patient's age. Soft tissue swelling may come into account, and also whether or not there's any bone destruction there. Now, the biggest difference between our cystic lesions that we looked at on the last slide and also these aggressive osteolytic lesions is basically how fast it's growing in the border. So a smooth border usually is going to suggest that there is some sort of slower growth process going on. And if we have a wide, poorly defined, moth-eaten border, it usually suggests to the radiologist or doctor that there's something faster and more aggressive happening, some sort of aggressive process happening. So again, with those aggressive osteolytic lesions, they can rapidly destroy the bone, so that bone loss can happen rapidly. So they're looking at the border, they're looking at the periosteal reaction, the age, and also the location of the lesion, and that's going to help them narrow down what the causes might be. Next extremity pattern is osteosclerotic bone lesions. So these are it basically means that the bone has become a lot more dense than it normally should be. So it's appearing wider per se, or brighter on our x-ray image. These lesions, when we look at them, they can be solitary, meaning single, or there can be multiple lesions. If there's just one small well-defined lesion or spot and the patient has no symptoms at all, sometimes it may just be a simple bone island, and bone islands are typically considered to be benign, or mostly can be benign. If there's a lot or multiple dense lesions, especially as the patient ages, let's say over the age of 40, they become a lot more concerned with things such as metastatic disease, so a cancer that's spreading. Another thing or cause, that's something that can cause an osteosclerotic bone lesion, is avascular necrosis that we talked about earlier. That's when the bone loses its blood supply, and as the bone changes, it can become more sclerotic or more dense. So we can also see sclerosis as part of the healing process, such as if a patient had a fracture, we can see that sclerosis or more dense area happening around the fracture after treatment, especially if it was a previous lytic lesion there. Another condition that we might see this bone lesion is the Paget's disease. It can also make bone look more dense, but it usually causes other changes too. And those changes that we see in Paget's disease are bone enlargement. We might see prominent trabeculae within the bone, and we also might see cortical thickening. When we say cortical thickening, we're talking about the cortex of the bone. So the cortex is like the strong outer wall of the bone itself. So the outer edges become more dense or wider or brighter on the image. So again, when we're looking at osteosclerotic bone lesions, it basically just means that the bone itself looks more white or more dense, too dense, more dense than normal. So then we have to ask ourselves, or the radiologist or doctor has to ask themselves, is it just one lesion or are there multiple lesions? They do also take a look at the patient's age and then the rest of the bone pattern to help determine or nail down what disease process is actually happening within the patient. All right, the next two slides are going to focus on periosteal reaction. So the first one that we're going to focus on is localized periosteal reaction. So the periosteum itself is the outer covering, that thin outer covering of bone. And when that periosteum gets irritated, it can respond, and it usually can respond by, I'll say, producing, creating, laying down, per se, new bone. So one of the clues when they're looking at this is what that new bone looks like. If that reaction is thick, if that reaction is smooth, if it's solid, it usually can suggest that there's some sort of slower process or more organized process, such as healing, happening after some sort of fracture happens, or it can be some sort of benign condition that the patient is having. If the reaction it looks layered, spiculated, very irregular per se, that suggests that the bone is reacting more quickly to whatever's happening in it. So it's something aggressive happening. It can be something such as an infection, or it could be something like a bone tumor. So there's three words right there. It's spiculated, laminated, and also amorphous. So if you want to know or have an idea of what spiculated means, that basically means it looks kind of spiky. So the new bone is going to stick upwards in like thin, sharp lines, almost like sun rays or needles, and that can suggest to the doctor, to the radiologist, that there's some sort of aggressive process there. If it's looking laminated or layered, that means the new bone is forming in several layers, like the layers of an onion. So this is why you might hear the term onion skin type of appearance, and that other term there, amorphous, that just basically means it's shapeless or it's kind of messy. So that new bone doesn't have a clear or clean pattern. It just looks very irregular, very disorganized, and also very cloudy like. So, an example of some of these things, such as if in the condition of Ewing sarcoma, it can produce what we call a layered or onion skin-like periosteal reaction. With osteosarcoma, it can create a more spiculated sunburst type appearance. So I do challenge you to look in your book or also Google these to kind of look at what Ewing sarcoma looks like, and also what an osteosarcoma looks like. You definitely, when you see it, you know that it is not normal. So the main thing when it comes to periosteal reactions, and we have another slide to go to in terms of periosteal reactions, is the periosteum is reacting. Periosteum, meaning the outer covering of the bone, is reacting in response to whatever's irritating it. So usually if it's a smooth and solid reaction, it's a slower process that's affecting the bone. If it's a interrupted, layered, spiky type reaction, there's something pretty aggressive happening to the bone. So we took a look at the localized reactions. Now we're going to take a look at the generalized reactions. So the biggest difference between the localized reactions is that instead of new bone forming in just one small area, the periosteum itself is reacting across multiple bones, and also it can react across the entire limb as well. So this usually makes the doctor or radiologist think that there's something systemic, there's some sort of systemic problem, meaning whatever's happening is happening or affecting the entire body, not just one local injury or one local point. So one of the more important causes of this generalized reaction can be vascular stasis. So that's where blood flow is not moving like it normally should, especially in the lower extremities. So that poor circulation can stimulate new bone formation along several bones. Another condition that could cause this is hypertrophic osteoarthropathy, and this can happen when the patient has chronic lung or heart disease, and it also may cause things like digital clubbing, new bone formation, and also painful swollen joints. So with that condition, hypertrophic osteoarthropathy, it's a condition where, again, your body or the patient's body starts trying to make extra bone along the outside of the long bones, usually because there's another disease somewhere in the body or somewhere else in the body. So a simple way to think about this generalized reaction is the bones are reacting to the fact that there's some sort of chronic problem somewhere else. Most often, it's probably going to be in the lungs, or it can also happen in the heart as well. So there's several conditions that are listed here that tend to be more common, and those are congenital infections. Also, some of them are metabolic disorders, and some of them can also be some childhood conditions as well. So, the big takeaway here, the difference between, so we talked about localized reactions that makes us think that the problem is just in one area, with generalized reactions that makes us think, or makes the doctor think, that the process, whatever's happening, is affecting the entire body. We're going to take a look at radiodense metaphyseal bands. So this is basically, it means that we are seeing some sort of white line, a horizontal white line near the metaphysis. All right, we're talking about the part of the long bone that is very close to the patient's growth plate. The bands can happen for several reasons, and we can see the causes right here on the side. If we're talking about young children, especially under the age of 3, they can sometimes, this band can sometimes be what they consider a normal finding. They can also appear when the patient's bone is trying to heal from something, especially some sort of period of illness. It might also be malnutrition, or some sort of other growth due to stress that's been placed on the bone. An example of where we can see these metaphyseal bands are patients that have rickets, healing rickets. So the patient is healing from rickets. As that bone starts to mineralize again, we start to see these dense white lines appear near the patient's growth plate. And again, we can see this on imaging. Another cause of these bands can be lead poisoning. So when the patient has repeated exposure to lead, it can produce these multiple dense bands, because each period of toxicity, when the patient is dosed with this lead, it can interrupt what we consider normal bone growth. So it leaves behind another line. So I like to think of it as, when you look at the tree lines, when they cut the tree and they can see the years and years of growth, meaning in the tree bands, that's what I kind of liken this to. All right, when we see these bands with conditions like, or we can see these bands with conditions like trauma. We can see it with osteopetrosis. If the patient has had leukemia, we can see these bands on some of their images after treatment. And scurvy can also show these bands on imaging as well. So again, this radiodense band that we're seeing near the growing end of the bone, near that growth plate, is usually caused by things like you see from this list. Now, one of the things that when we talk about the metaphysis, we're talking about the area near the growth plate. And when we're talking about the radiodense band, when we're looking at it on imaging, it appears kind of like a white line. So if we're seeing multiple bands, we're seeing like multiple white lines where the growth of that bone was interrupted. We took a look at what radiodent metaphyseal bands looks like. So now we're going to take a look at what radiolucent metaphyseal bands looks like. So radiolucent basically means that when we're looking at it on an X-ray, it is darker. So the metaphyseal band, radiolucent band, means that it is going to appear darker near the growing end of that long bone. So that dark band usually can tell us, or tell the radiologist, that normal bone growth has been interrupted in some kind of way. It can happen with some sort of serious illness. It can also happen with trauma. It can happen with infection, and it can also be as a result of some sort of systemic disease process. Now, an example of a process that can cause these radiolucent bands is leukemia. So, when the patient is diagnosed, the metaphyseal bands may look dark. After they have finished up with chemo, those same areas might start to look more dense or more white. So, the x-rays can actually show us somewhat the treatment timeline based on the color that is presenting in the band, whether it's dark or whether it's white. When we see a radiolucent metaphyseal band, sometimes we can see them in conditions like congenital syphilis, meaning the patient was born with it. We can see it with scurvy. We can also see it again with trauma, illness, severe childhood illness for sure, and also with scurvy. So one of the ways to remember this is radiodense mediophyseal bands are white lines. So we talked about that on the previous slide. And radiolucent metaphyseal bands are dark lines. And the dark lines suggest to the radiologist or the doctor that the growth or the mineralization at the growing end of the bone has somehow been disrupted in some way. So again, radiodense is a white band, radiolucent is a dark band, and both of them are going to occur near that growth plate area, but they tell us a different story in terms of what is happening to the patient's bone growth. So here's just some key points that we talked about in terms of the extremity pattern. So a way to quickly kind of sort through some of the lesions. Again, not trying to memorize all of these diagnoses, but the first thing that we learned tonight was we want to look at the location, and we also want to look at the patient's age, because the same dark bone lesion might mean something very different if we're talking about a teenager versus a patient that's 60 plus years old. An example would be if we're seeing some sort of lucent lesion around the knee in a younger patient, it might be something benign like a non-ossifying fibroma, whereas if we're seeing that same area on a older patient, then we could be more concerned with something like metastatic disease or myeloma. The second one is the zone of transition. So basically we're talking about the border between normal and abnormal bones. So if we're seeing a sharp, narrow border, it usually suggests to the doctor that whatever's happening is probably benign and it's growing slow, or it's, spreading very slowly. If that area or zone of transition is wide and fuzzy, it kind of piques the doctor's interest that it might be something more aggressive happening with the patient. The other thing that we talked about tonight or today was periosteal reaction. If we're having a thick, smooth reaction, that means that the bone is having time to respond, and it's a slower process at hand. Something more slow is growing or affecting the bone. If it's spiculated, or if there's some sort of onion skin pattern, it suggests to the radiologist or doctor that there's something more aggressive and moving faster in terms of what's affecting the bone. The last thing that I'll mention here is there's a couple more things that we talked about. Clues, I guess, per se, when it talks about the extremity patterns. One was with frostbite. With frostbite, it was noted that the thumb itself might not be affected. It might be spared. And the reason for that is when we get cold, a lot of times we clench up our hands, and sometimes we might clench, the thumb within, the fist itself. So that sometimes means that the thumb will not be affected in terms of frostbite. Another thing that we looked at was leukemia. So with leukemia, we might see on their imaging dark metaphyseal bands. They may be seen more so after their chemo process. So the x-ray can actually give the doctor a clue of actually when that treatment response was over to that chemo. So again, when we're looking at all of these extremity patterns, we want to take a look at the patient's age because that can be helpful. We want to take a look at where the issue is happening, the location, because some things like places better than others. They like locate certain locations better than others. We want to look at the borders of the lesion. Is it, smooth and well defined, or is it very messy? That tells us if it's growing very slow or if it's very aggressive. And then we also want to look at the periosteal reaction. That can tell us a lot about whether or not that bone lesion is, or that process is growing slowly, or if it is very aggressive as well. Our next two slides are on quick recognition patterns. All right, so we're trying to connect some of the findings to some of the conditions that can, I guess, show or appear in terms of imaging. So if we're seeing resorption at the fingertips, but the thumb itself is spared, meaning not affected, one of the things that the doctor may think about or the radiologist may think about is that the patient may have had frostbite. And that's because, again, when we get cold, sometimes we clench our fists, and sometimes the thumb is protected as a result. If we're seeing multiple calcified loose bodies, and we're seeing those loose bodies within the knee of an older patient, they sometimes tend to think of DJD, or degenerative joint disease. If the epiphysis looks ballooned out or enlarged, and there's some sort of joint osteoporosis, sometimes they tend to think about conditions like hemophilia and juvenile rheumatoid arthritis. If we see, or the doctor sees, what they consider well-defined dark lesions, with the borders being very sclerotic, especially if it's in the knee area of a patient that's under 30, they sometimes think about non-ossifying fibroma. And if we're looking at or seeing something that's moth-eaten or poorly defined, they tend to think about lytic lesions within the soft tissue mass, especially if we're talking about a patient over 40. They might become concerned with the process, a metastatic disease process. So again, as we talked about pretty much all this extremity pattern chapter, we want to take a look at the age, we want to take a look at the location, the border, and also we want to associate the findings, the clinical history with it as well. This is our last quick reference slide for our extremity patterns. And again, these are just things that can help us narrow down what we're dealing with in terms of the patient. If we see multiple small dense spots in the bone, so we're talking about on imaging, the patient presents with no symptoms whatsoever. They might tend to think about bone islands or osteopoikilosis. These are usually going to be more benign. If we're seeing an onion skin periosteal reaction, and there's also large soft tissue masses, they may be concerned about Ewing sarcoma. That layered periosteal reaction from that description of onion skin periosteal reaction basically tells the doctor that there's something aggressive that's happening, some aggressive process happening within the patient. If the periosteal reaction is symmetric and wavy in several bones, and the patient also presents with things like digital clubbing, they may lean toward hypertrophic osteoarthropathy, which also can be associated with heart disease and also chronic lung disease. If we're seeing multiple dense metaphyseal bands, especially after the patient has had repeated episodes, they may tend to think of things like some sort of poisoning, specifically lead poisoning. And last but not least, if we are looking at metaphyseal bands that are dark at the diagnosis and they become more dense after chemo, they tend to think about or not think about, they can tend to lean on the fact that the patient might have had leukemia. So that can actually change after that response can actually change the color of the bands after the patient is done with their chemo treatment. So again, these are just quick associations that we learned over this extremity chapter. Dent spots, bone islands, onion skin. We're going to think about Ewing sarcoma, clubbing plus periosteo reaction, hypertrophic osteoarthropathy. If we're seeing those dense metaphyseal bands, we might lean toward things like lead poisoning. And then if we're seeing bands that are dense after some sort of treatment like chemo, we tend to lean towards leukemia. All right, and this brings us to the end of our extremity patterns chapter. So some of the big takeaways for these extremity patterns are listed right here. So when we see an abnormality in that long bone, some of the things that the doctor might start asking is where is the pattern located? So is it near the growing end? Is it in the shaft? Is it along the surface of the bone? Or is it inside or nearby some sort of joint? They then want to ask what the patient's age is, and also the border of the lesion is going to narrow some things down for us. When I say the border of the lesion, is it a messy border or is it a well-defined border? That's going to tell us whether it's an aggressive tumor or process versus if it's a slow process that might be more benign. Now, we did learn about some mnemonics again, and those mnemonics basically kind of help organize some of the possibilities for some of these conditions, and that one of the mnemonics was phlegmomassic, and it's basically useful when we're looking at those well-defined cystic type lesions. And the other acronym that we learned about was lemon, and that's useful when we're looking at some of the more aggressive round cell type lesions that can look similar in the shaft of the bone. Now, for any lytic lesion, two of the fastest things that we typically are going to check, or two of the things that we're going to check, are the zone of transition and also the periosteal reaction. And we briefly mentioned that initially. So is the border sharp? Usually, if it is, it's going to suggest that there's a slower process. If the border is wide and fuzzy, it's usually going to point to the fact that there's some sort of aggressive periosteal reaction happening within the patient. Last but not least, some other patterns that we talked about were frostbite and the fact that the thumb might not be affected. We talked about scurvy. I don't recall talking about this Wimberger ring sign in any of the slides, but the Wimberger ring sign is basically it looks like a white ring, and that ring is around the epiphysis, and it's usually caused by scurvy. It happens because the outer part of the patient's bone usually is going to stay relatively dense while the surrounding bone is going to become a lot less mineralized. So that Wimberger sign is a sign for patients that may have had or might be overcoming scurvy. The other condition or pattern that we looked at was the Ewing sarcoma, and again, it produces that onion skin-like pattern or periosteal reaction. So again, these are just a few of the conditions that we looked at. There were many, of course. Again, when we're looking at these on imaging, yes, we should know right away that they are abnormal because we should know what normal looks like. But just because it looks abnormal doesn't mean it's necessarily harmful to the patient. Doesn't mean that it is malignant, because it could actually be benign, or it could actually be normal for a patient of that age. So we're going to also look at the patient's age. Again, we're going to make sure we're looking at the location, not us, but the radiologist and doctor. And then they're gonna look at the border as well to see if it's messy or if it's well defined. And last but not least, they're gonna look at how the bone is reacting to whatever is attacking it. So thank you for listening to this week's lectures. Again, we had 3 long chapters. We started off with spine patterns, then we delve a little bit into skull patterns. So we started with skull patterns, then we dug a little bit into spine patterns, and we ended with some of the extremity patterns. So again, our job is not to diagnose, but we are the first people that the patient sees. We're the patient that's responsible for their diagnostic imaging. So if we see something and the radiologist is available, and let's say this is an outpatient, we don't want to just send the patient away right away. We may want to just go take a quick look and ask the radiologist, is there something else that we need to do with the patient before we let them go? Usually it is going to be probably a quick call if they're seeing something, especially if it's a very aggressive metastatic type process. They're probably going to want to get in touch with the patient's provider right away so that they can go ahead and schedule whatever's to follow, whether that's advanced imaging, whether that's some type of staging, some type of biopsy. We want to ensure that we can get the patient to their next step a lot quicker, especially if we're seeing something that is abnormal. So again, thanks for listening.